Good morning, and I would like to welcome everyone who is present in the chamber and all those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would like to add that for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also request that all members place their phones either on silent and ensure that everyone has the opportunity to ask questions, to ask a maximum of 2 questions per item and to keep these succinct and concise. However, I will close down the debate to ensure we keep to time if needed and would ask you indicate early to guarantee your question. As the meeting is being streamed in the usual way, I would like to remind you all that your comments will remain accessible online as the meeting recording remains on the council's website. I'd now like to move into agenda item 1, apology for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies for absence for today from Councillor Makinson-Sanders and also from Councillor Jeanette McGee. We've also had an apology from Councillor Sue Woolley, Executive Councillor NHS Liaison, Integrated Care Systems, Registration and Commoners. Thank you, Chairman.
Thank you, Trina, and I'd like to welcome Councillor Glynis Calacey back to the committee as well. Nice to have you back with us. Thank you. We'll move into agenda item 2, declarations of members' interest. This is an opportunity for members to raise any interest, pecuniary or not. Councillor Kendrick, please.
Thank you, Chairman. Just my usual one. I'm a stakeholder governor of the Links Partnership NHS Foundation Trust. Thank you.
Thank you, Councillor Kendrick. Any further? No. If any come up throughout the meeting, then please just raise and we'll get those noted. We'll move into agenda item 3, the minutes. To confirm the minutes of the meeting held on the 6th of December 2023 as a correct record. They are found on pages 3 to 13 of the agenda pack, and as the committee have had the opportunity to read these in advance, I plan on taking these on block. Can I have a proposer for these, please? Councillor Linda Wootton. Thank you. Seconded, Councillor Martin. All those in favour, please show. Thank you. Against? And abstention. Thank you. They're noted and they're carried. We'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda and supplementary announcements were circulated on the 23rd of January. Does anyone have any questions on the announcements? Councillor Smith, please.
Thank you, Chairman. With regard to the very helpful appendix that's been provided, Appendix A at your announcements, it's very disappointing that the data is not by cohort and is currently not available in this format, as this reduces the potency of that data contained in the announcement, as it doesn't give us the full picture of the data. It doesn't give us the full picture. Is the data alluded to collected anywhere else within the NHS system, or is it simply a case of the NHS doesn't hold such data, which I appreciate? It's probably more of a question for Simon than yourself, Chairman.
Thank you. I do believe they normally say it's experimental data currently in the way that they collect it, and so they're working it through, but I will bring in Simon just to add anything further.
Thank you, Chairman. Yes, the data on GP activity is often referred to as experimental data because some of it is incomplete, so we are told. But yes, I can certainly check if there are any other sources of the information that you're seeking. Thank you.
Thank you, Councillor Smith. Councillor Wood.
Yeah, thank you, Chairman, for your update on the Springcliffe Brant Road surgery. I understand the reasons why the board would want to merge them as one surgery, but I'm quite disappointed by it. I think we're already stretched enough for GP services as it is, and closing another one is just going to make that worse. I'm just intrigued at whether the consultation and the survey went out to just patients or wider Lincoln, because I think it is a wider issue than just the patients at the surgery. Thank you.
Yep, Simon, do you want to pick up on that, please?
My understanding that it would be circulated simply to the registered patients, but I will check that. But that's my understanding rather than a wider consultation.
We'll get that clarity and come back to you anyway, Councillor Wood, and we'll take it from there. Any other questions on my announcements? No, in which case do I have a proposer that we note these, please? Thank you, Councillor Hayes. Seconded, Councillor Smith. All those in favour, please show. Thank you. That's supported. In which case we'll now move into agenda item 5, the East Midlands Ambulance Service. This item was circulated as part of the agenda on pages 5 to 115, and I'd like to welcome our presenter via Teams, Sue Cousland, Lincolnshire Divisional Director for East Midlands Ambulance Service. I understand there was an additional item that came in as well on this, so I'll let Sue just allude on that if perhaps possible, and if I can hand over to you for about 15 minutes and we'll take questions at the end, please, Sue. Thank you.
Lovely. Thank you, Councillor Macy. Good morning, everybody. First of all, I do have Neil Scott with me. I think those of you who have been before to hear our presentation will know Neil as a head of operations for Lincolnshire Division. And Dan Scarrett is also here as an observer. He is our emergency planning manager and here to observe proceedings. There are a couple of issues that we would like to draw your attention to with the paper previously circulated. There is a typographical error on section 4.3, which Neil will cover in his update. And I have noticed, and it is my fault, the appendix is missing appendix 4 under 5.3, and that is the annual report from our clinical leadership team for 2022-23. That is the paper that Councillor Macy has just referred to, and I've forwarded it on to Simon Evans for distribution. It is included in the pack for information only, but happy to take any questions post-meeting if anybody does have anything. So going on to the paper itself, last time we came to see you was June 2023. And you raised, quite rightly, some issues, 4 issues with us. One around our performance for national ambulance standard targets, hospital handover times, recruitment and retention levels within division. So those were the 4 areas, and I've tried to pick those out within this report so that you can see the update. I've also included under section 3 an item from the Trust Board, EMAS Trust Board in January, which I attended as an observer, and I've taken extracts from the Chief Executive's report, and I'll draw your attention to section 3.2, the National Vision, that was actually created by the Association of Ambulance Chief Executives, known as AACE. And it has published its vision for ambulance services. And on page 2, I've actually taken elements out of that. The 2 elements that the National Vision is recognising as clear remits for ambulance trusts in the future is to be the lead coordinator and navigator for access to urgent and emergency care, and also to respond to patients needing out of hospital care with direct referral pathways. So again, I've tried to pick out where I think we are in Lincolnshire against those 2 particular points. So we have employed, as you know, I've spoken before about our pathway leads. They have done an extremely large amount of work on creating appropriate alternative clinical pathways for those patients who do not need to go to an emergency department. And hopefully through the performance section, you will see how some of those pathways are starting to play in. I've included a summary of their work as well in Appendix 3, so you can see how busy they have been and how supportive they are to the patients of Lincolnshire. I've also alluded to the additional funding that Lincolnshire has received, and you will see in the recruitment section what that has meant for us. In terms of recruiting additional, more specialist roles into the division, we've highlighted the specialist practitioners. There is an advert out at the moment, and we do hope to be able to recruit a number of people. We're having indication that people who perhaps previously left us are now looking to return to the division. So again, we'll report on that in future attendances. We've also looked at working our specialist practitioners working alongside all of the other services that are aligned to urgent and emergency care. And hopefully, as we take you through the paper, you will see that really strong alignment with our system partners from ICB through to other providers in the county. I'm now going to hand you over to Neil to take you through sections 3 and 4, if that's okay. Thank you, Neil.
Thank you, Sue. I'm Neil Scott. I'm Head of Operations for the Lincolnshire Division of EMAS, and as Sue's said, I'll take us through the next part of the paper. So the next section, section 3.3, which describes performance influencers, is just a graphical representation of what we're doing with the investment and the future plans in the medium term in terms of what does EMAS look like. These are mainly focused around capacity, demand and supporting staff. And the graphic in the paper makes it clear that the fundamental piece that improves ambulance service delivery in Lincolnshire and regionally is that capacity increase. So we're recruiting staff, we're putting clinicians into areas where it can manage demand, such as our control room, so that we can deal with things more upstream before it either gets an emergency response or develops into a worsening situation. The primary, however, piece that's been discussed here before, and the one that is most in the forefront of people's minds, however, is performance and where we're sitting in performance. So that's section 4 in the paper. Now, EMAS, along with other ambulance providers nationally, have been working with NHS England from a regulator point of view, both regionally and nationally, in terms of what does that improvement look like. And we've recently gone through a modelling tool with the national team, which looks at what does an improvement trajectory look like for East Midlands Ambulance Service. And the reason that was done is because, to simplify it, injecting investment in, say, April doesn't immediately equate to there's more staff, there's more ambulances, there's a greater ability to respond. It takes time to build up that capability. So taking into account the realistic aspect of more staff, more vehicles, etc., our revised trajectory position is a financial year end of 39 minutes, 49 seconds as a region. The next section in the paper just defines what the various categories of ambulance response are. And the main currency that the report discusses and that is in the sort of national attention is category 2 mean time. That's the primary unit of measure. The reason for that being that category 2 calls make up anywhere between 70 and 80% of ambulance activity nationally, regionally and locally. So it's the best measure of how an ambulance trust is performing. There's a slight typo on the second line of 4.3. It says in the paper November 23, that should be November 22. So to put this into context of where our C2 performance is, in November 22, our category 2 mean response time was 65 minutes. In December 22, it was 176 minutes. In the months just gone, as a division, that was at 41 minutes and 50 minutes respectively. So a significant shift when you look at 22 to 23 by a huge amount of time and performance. The next part, activity, just shows what activity has been like historically for us in Lincolnshire Division. There's not a huge amount of fluctuation in activity. What does happen within that fluctuation is the acuity. What do I mean by that? That's how sick people are, how time critical patients are, what's wrong with them. And that can be influenced by the weather, that can be influenced by other events that have an external factor on people accessing healthcare, being that primary care access, be that industrial action, etc., etc. So while the activity tends to stay fairly static, the what's within it is the bit that changes. The key issue for us, especially in Lincolnshire, is about protecting our A&E departments, which are, as we know, it's a struggle to keep the A&E departments where we want them to be. And on page 7, it's a fairly busy set of data there, but the key one in the top part of page 7 is a percentage ED conveyance. Now, what that means is, what percent of patients do we transport to an emergency department? And that's brought out in the table in 4.5, which shows that as a division, Lincolnshire is at or better than the regional and national position in terms of we take less people to an A&E department. So we really strive through either hear and treat over the phone or see and treat when we see people in person to be directing people to the appropriate pathways, which more often than not, it's less than 50%, is not an emergency department. It's community care, it's advice, it's self-care, it's other options. 4.6 goes into detail in terms of our resourcing position. Now, the way of delivering an ambulance service and delivering an ambulance service performance is fundamentally that balancing act of the more hours you have for response, the more resources you have for response, the better the performance will be, the better the experience will be for the patient. So the vast amount of our investment is fundamentally on staff to provide more respondable staff and vehicles to the people of Lincolnshire. And what section 4.6 specifically in figure 10 and 11 shows is that growth of output hours per month available to the people of Lincolnshire. It's a mixture of what we put out as core Lincolnshire Division EMAS, but as well as our private ambulance provision. And the reason we have private ambulance provision is it goes back to that piece I was saying earlier. It takes time to develop staff. To take someone from a new entrant student paramedic through to a fully qualified paramedic is years. To take a technician with no prior experience through takes a number of years as well. And private ambulance provision is effectively the agency of the agency work of the ambulance service. So it provides that stopgap and that extra rapid response capability while we're building up our workforce, while we're building up our extra fleet. And you can see in those graphs that from sort of October, November, we've had that real upsurge of ability to put out more resource. Going in that same vein of resource output and resource availability being key, section 4.7 shows where we are in terms of our sickness and absence management.
Just going to stop you for a second, Neil. I think we've got totally different numbers to you. We're on, I think, 3.7, not 4.7. And of course, our page and numbers are also different. I think we're on page 33. It's just so the committee's aware. I think it's literally 3.7, not 4.7 in our actual agenda pack. So if you can then sort of follow it from that point, and I'll hand it back to you, Neil.
Certainly, apologies. That's as you said, different to the one I've got. So the table showing sickness and absence management with regards to Lincolnshire Division versus the rest of the organisation shows that we are leading the way in terms of our sickness management, keeping our staff at work and responding to the people of Lincolnshire. Now, the next section I'll just go on to is one that's been discussed in this forum many times before, and it's always a topical one. It's the area of pre-handover in the sense of hospital delays and hospital queuing, to put it in more simple language. So that has always been an issue locally, regionally and nationally in terms of ambulance service delivery, that lost hours element of queuing as opposed to responding. And we've seen some big numbers and big fluctuations in that, both when you look at Lincolnshire Division as a whole, but also when you look at specifically United Lincolnshire Hospital's specific sites at Lincoln and Boston. And we saw a big increase in those as we moved from September into October. But equally, a significant shift when we moved from October into November. To take the divisional figures, in October it was 6,400 lost hours prior to handover, dropping down to 3,300 when we moved into November. And that's graphically shown in the next page in terms of that big spike in October of lost hours from a pre-handover point of view. A lot of that is multifactorial, and it's many of the issues I mentioned earlier in terms of it's the beginning of winter. There's industrial action that was happening across multiple sectors of the healthcare environment, and lots of competing delays coming together to a single point in time. However, November of the 2023 represents a real period of what it looks like when everything's aligned and everything is flowing the right way. So we saw a reduction in those hospital delay hours. We saw a big increase in our staffing, our resource availability of our output hours. And all those came together to really give a period of stability where we had really good performance and really good response to the patients that were calling us. And it was a really good time to show what happens when we have that vast period of improvement. That's not all us by any far stretch. That is a system approach that has delivered that. That is our colleagues in Lincolnshire Community Health Services, Lincolnshire Partnership Foundation Trust from a mental health point of view, and very much so our colleagues at United Lincolnshire in terms of recognising that patients who phone 999 represent some of the biggest risk in the urgent healthcare arena when they've not had a response, and putting that risk front and centre, and everyone as a system approach, delivering what they need to deliver to make sure that that risk is taken down. And what that looks like at the end result is as an improvement in those category 2 performance times. And just in the very, very last graphic of that section, figure 18, which I'm hoping matches up, shows in ringed in red there that stars aligned position of everything coming together to deliver greater performance. The paper doesn't show it because it wasn't there when it was written, but just to put that into perspective, we've always historically been in a very difficult position for category 2 performance in Lincolnshire, but this month to date, fundamentally, as both as a division and as an ICB area, we are leading the way across the whole region in terms of Cat 2 performance. So definite sign of improvement for not just Lincolnshire division, but the people of Lincolnshire as a whole for their response from EMAS. That's the end of that section, and I'll hand back to Sue.
Yes, thank you, Neil. I will pick up, I won't use numbers, I'll pick up with the headings that I'm just going to pull some salient points out. So I'm on the section marked quality initiatives. We now have a divisional senior manager for workforce. That position has been secured for 2 years and has a very experienced existing member of the team with quite a unique skill set working in that. And it's Rich Hunter who will be working with the system and regionally to pull together a workforce plan for Lincolnshire, and that will be a first for us in that level of detail. We also have attracted some additional central funding for somebody to be put into post to look at internal efficiencies within the job cycle that Neil has just referred to from a performance perspective. So there is a lot of work going into that. That position started at the beginning of January, and we're already quite a long way down the line with some key actions in a plan to improve internal efficiencies. Clinical leadership, again, I've spoken to you before about the unique and very skilled clinical leadership team in Lincolnshire. The omission is Appendix 4, and that is an overview of what they were doing in 2022-23, which hopefully you will find of interest. If I move on to recruitment and retention, again, this was mentioned last June, and justifiable concern was raised, particularly in relation to our skill mix and our attrition. As you can see from figure 20, and hopefully that does align, our attrition rate is lower than expected, which means we are retaining more staff than we had anticipated, which is good news. We do undertake exit interviews for anybody who leaves the organisation, and we then review whether there are any particular themes. The exit interviews for the last 6 months are across all grades and for a variety of reasons, not one or two in particular. You will see, though, that our skill mix is still quite poor. It is about 33% registered personnel, so that's paramedics and specialist paramedics. So we're doing work to actually try to increase that. We have included our recruitment trajectory for Lincolnshire, and that is on the back of the additional funding that Neil has already spoken about. We are going to be in receipt of the largest number of new recruits, both this year and next year, 2024-25. That is a great place to be, but with a lot of new recruits, predominantly newly trained, newly qualified individuals, that then comes with additional issues that we are picking up, and we will be providing full mentorship support. We're also looking at portfolio careers because we do have a proportion of our staff who are perhaps coming to more of a twilight of their clinical career when frontline ambulance work is actually not as easy as we all get a little older, and I include myself in that. So we're working alongside system partners to look at portfolio careers so that we don't lose those individuals. Staff engagement is key to the whole leadership element in Lincolnshire. We have what we call chatty cafes, where we take a vehicle with tea and coffee making facilities out into the community, out to emergency departments. We don't go to stations. We've mentioned this before because staff don't go to stations other than for their meal break. So we meet them outside emergency departments and we talk to them about what's important to them, and we listen to what's important to them, and hopefully try to make some changes where we can. Staff opinion survey is completed for this year. We have not yet received the results, but again, at a future attendance, we will update on the staff opinion survey. I have included a whole section. You asked for something specifically on Storm Babette. And Dan has prepared for us a whole section, because one of the things that a lot of people don't realise about ambulance services is that we are a Category 1 responder under the Civil Contingencies Act. And we've detailed that for you because that actually is a huge part of the role that we provide both nationally, regionally and locally. Storm Babette did take its toll on the system, but as an ambulance service, we did not have any form of significant impact from that, other than attendance at coordinating groups, both at a tactical level and a strategic level. We have since then attended a number of other storm-induced meetings around planning and how we feed into the system response, not only at the time, but also in recovery. So we have detailed that for you in the number of meetings that Neil and colleagues attend at tactical level, and I attend at a strategic level. We've also included training figures around emergency preparedness for both the managers and for the staff in Lincolnshire that is mandated to us, and there are significant recommendations out of the Manchester Arena reports that organisations such as ourselves and other emergency providers are working through at the moment. So in summary, Councillor Macy, I think this report demonstrates an improvement or an improved position on where we were when we last visited you in June last year. The report highlights we are taking less people to hospital if they don't need to go. We have an improved resourcing picture. We have the best sickness record regionally. We have reduced our attrition. We have a new approach to workforce now and in the future. We are very lucky to be an integral part of the system in Lincolnshire, and we feel very privileged to be working alongside colleagues because there is genuine collaboration between providers and commissioners in Lincolnshire. And our focus is turning now to our own internal efficiencies with a plan to improve that position. So that concludes the report for the Lincolnshire Division of EMAS. Thank you very much.
Thank you for such a very thorough report and presentation. I've got Councillor Allen first, please.
Thank you, Chairman. Yes, I would like to say the same. It was a very thorough report. And it does have some good news, I think, within it. I've got a couple of points of clarification, more for my own use than anything else. as well as a couple of so those are questions as well as a couple of statements. Could I be informed what the delays are in terms of the two categories that are contained within the report? The delays post handover, which I can understand. That's waiting to get the patients out the ambulance into the hospital itself, presumably through A&E. But I'm not totally sure what post handover delay is. So if they could perhaps give me a response to that. Sickness, I think, may well be static or may well be marginally improving, but it's still quite high. And I just wonder whether there's any response to that in terms of at least identifying the issue, that it is quite high. Certainly within the overall employment sector. I don't know whether it's high within the public sector or the health sector. So perhaps that could be covered as well. And I would like to have a view, I think, in terms of the improvements that we do see. It's very good to see a November improvement of the form that we did, but it is bookended against still quite a lot of variability both before and after that. But resources are improving. There's various initiatives taking place. So when are we likely to see a significant long-standing improvement over a number of months? Because November is good, but I think I would like to see more months of that sort of form than just 1 month. But overall, I think the progress is good. I think it's still a question of keeping a view on things, because the ambulance service is such an important part of dealing with health issues within our communities.
Thank you, Councillor Allen. I'll pick up the sickness question that you've raised, and I'm going to refer to Neil for the post handover and the sustained performance question. So high sickness, yes, our sickness rate is still high. We are aiming for a 5% sickness figure regionally, which is in line with national expectation. But I guess what I would like to portray is we have an ageing workforce. We have a large musculoskeletal reason for absence, which aligns to the more mature workforce undertaking a very physical role. We also have some members of staff, sadly, who've been exposed to a large number of very traumatic incidents, and they do have to take time away from work, and we support them for that. So those are our long-term sickness elements. Our short-term sickness elements, we, like everybody else, are not immune to COVID, to flu, to coughs and colds. And when you are dealing with poorly patients all of the time, you are more likely, as our colleagues in acute trusts and elsewhere, you are more likely to be exposed. And despite all of the precautions that are taken, unfortunately, staff do succumb to the nasty bugs that are around at the moment. And I think through public health colleagues, we are learning that because we were all locked down for a significant period, the bugs that are circulating at the moment are significantly virulent because we were all protected. Apologies, I'm slightly distracted because I am on call for the region today, and we've just lost power at our EOC centre at Bracebridge. So with your blessing, I just need to nip out just to see what the current situation is. And may I just hand over to Neil in the interim, and I'll be back in a couple of minutes. Thank you.
No problem at all. Thanks, Zoe.
Yeah, and to follow on the other points, so there was one point regarding when will we see that in a sustained position. So the January position for the month we're currently in, month to date in the Lincolnshire area, we're at 41 minutes for our C2 mean. So that's virtually the same as where we've seen in November. Bearing in mind January historically in the NHS is one of the busiest months in terms of both cold weather, but also hospital pressures, etc., as you come out the other side of Christmas and New Year. So 41 minutes puts us back into the where we were at in November position, and moving through the rest of Q4 up towards April, our trajectory is very much looking like much closer to 30 minutes as being the standard position rather than closer to 40 minutes. So I'm foreseeing Q4 being that period of stability as we move forward. In terms of the pre and post handover and what's the difference, so you're absolutely right. Pre-handover is the point between putting the handbrake on and handing over to the clinical staff in the emergency department. And that has huge variability in terms of how long that pre-handover period is. Post-handover is the actions that need to take place before the vehicle is available to respond again. So that could be restocking, that could be cleaning the vehicle. If it's a time-critical patient, such as a cardiac arrest, you're doing CPR or some other intervention en route to hospital, then there is no paperwork taking place. There's no documenting of actions, etc. So it can also encompass at times writing up the incident before you're ready to move on to the next one. Thank you.
Thank you. I've now got Councillor Kendrick, please.
Thank you, Chairman. Just a couple of questions or clarifications needed. First one's on staff engagement. I was pleased to see that the chatty cafes are still going. I remember we had that mentioned at a previous meeting. I was just wondering, as regards to the staff survey, what the sort of response rate is expected to be. Because I know sometimes such surveys, it's quite a low response rate in the NHS. So just wondered what the last one was, and obviously we can't know until we get the actual result for the current one. And the other point, Chairman, I was interested about portfolio careers. I just wonder if you could expand a bit more on that. I seem to remember, again from a previous meeting, there was mention of paramedics being in GP surgeries, people who are approaching the end of their careers and so on. But I just wonder if we could have a little bit more on portfolio careers and, as I say, the response rates that we get on the staff survey. Thanks, Chairman.
Certainly. So to answer it in reverse, the portfolio career piece is fundamentally a recognition of what has happened to both the NHS as a whole, but also the ambulance sector and the paramedic profession. So historically, and when I started as a paramedic 20 years ago, being a paramedic meant you worked in the ambulance service. That was it. Whereas now there's a multitude of careers, be that higher education, research, primary care, event work, etc., etc. There's a lot of different options available. What we're trying to do with our approach to our workforce is for staff that choose to have multiple experiences through their career, to make that easier for them. So, for example, we have a specialist paramedic in Lincolnshire who works for us X days a week, but also works in a GP practice X days a week. They have two employers, in effect. And if I'm honest, the historical position would probably be one of, well, you either work for one or you work for the other. Whereas that's a very short-sighted approach. You know, the experience someone gains working in, say, primary care is completely useful across both those regards. We have other staff that work in the control room environment in terms of dealing with callers over the phone and providing clinical advice, and also have secondary contracts in an operational response point of view. We also have other staff that are lecturing at Lincoln University in a paramedic science format, where they're teaching the future of the profession. Equally, they have a contractual arrangement with us where they work in a response element as well. With regards to the staff opinion survey, apologies, I don't have the numbers directly in front of me of what last year versus this year's response rate was. Happy to provide that as a written response. I don't know whether Sue has it to hand. I doubt she does, but we can happily provide that as a follow-up written response.
Apologies for that slight disruption. No, I don't have the figures to hand, but we will provide those to Simon for onward distribution.
That's lovely, thank you. I've got Councillor Smith next, please.
Thank you, Chairman. Could both the presenters give us a bit more detail on what these new roles, in terms of, because it's mentioned in the report there's a number of new roles, what the skill mix will be, and this may be a slightly cynical view, but I do have a worry when one of my former residents in another ward I used to be in told me about how radiographers and things had changed in the skill mix, and she was a former nurse. And I suppose it's always a worry, is it's a de-skilling. Now, that may not be the case, Chairman. I don't know enough about it, which is why I'm asking the question. I hope it's not. I hope it's actually more of a means of levelling people up so that they can do more rather than levelling things down, so somebody with less experience can do more without the sufficient training. Secondly, Chairman, with what's contained in Appendix A for our report, if implemented in the manner hoped for, how will this impact on what we see as, if you like, the day job for paramedics, which is in the ambulance, treat people either on scene or to a hospital, whereas in Appendix A they're being asked to do an awful lot, Chairman, an awful lot of new things that they don't currently do, and it doesn't say, particularly in massive detail, where that additional funding is going to come from, if there's additional funding, or is it something that they're going to be expected to do sort of as business as usual, if you like, on top of what they already do. And finally, Chairman, it's not a question, it's just to put on the record. The reason, as he said in the report, the reason that the ambulance service is so stretched is because our residents know that is the one service that they can see. And it's a bit of a sorry situation, Chairman, that actually the amount of people will go, well, I phoned the ambulance because I couldn't see the GP, or I couldn't get into X treatment centre, or I couldn't get somewhere else, so I phoned the ambulance because I'd left it weeks and weeks because I couldn't see anybody. And actually, we as councillors and also our members of parliament need to be having quite serious conversations with those other areas of the National Health Service to say, you cannot keep putting a strain on our ambulance services because you are actually stopping them doing the job they were intended to do for. You're putting additional load on them that actually isn't fair for them to take because it's a failure in other parts of the system that's giving them that load, and that needs to stop, Chairman, and we need to do what we can to, shall I say, extricate that situation in stopping, because it's unfair, which is why we see some of the times for Cat 2s and Cat 1s that we did see. And I would just like to finally pay tribute to our presenters and everyone that's working at EMAS to bring those down to quite a remarkable difference this time from last winter. It's a huge improvement, and well done to everybody concerned.
Thank you, Councillor Smith. That is very much appreciated, and we will pass that on to all members of the team. So if I may take your questions in reverse order, if I've understood them correctly, and that is members of the public not being able to access other areas of healthcare for appropriate advice, leading to additional strain on the ambulance service. I think that is very well recognised, and I think the same could be said for GP practices and emergency departments in particular as well. They're seeing a lot of very poorly patients, but they're also seeing patients who could access alternatives to those options as well in order to employ a little bit of self-care, if I might say so. Certainly the younger generation don't seem to access a lot of options that are available to them for more minor issues. They choose rather to try to access other services. So I think there's a lot of education that has already been undertaken, particularly by the ICB, about using the most appropriate areas for your particular concern or health concern. That will continue, but I also think there is a role for all of us to try to educate members of the public on the most appropriate levels of care, and also that self-care that I've mentioned. So hopefully that gives some reassurance that the system is sighted on that and is working collectively to change that position. Sorry, I'm still being slightly distracted by messages coming in on the screen. In relation to Appendix A, that is a national vision for ambulance services. And that's what I've tried to pick out the salient points out of that and give you an indication of how far advanced Lincolnshire division is against some of the points that national vision is articulating. So apologies, Councillor Smith, if I didn't quite understand that question, but I was really trying to point out that we have made a lot of progress against some of those points already, and working again was an integrated part of the system. I'm very confident that we will be able to continue that. And then the dilution of skill mix, yes, as a nurse myself, I am acutely aware. What we're talking about with our workforce plan is probably exactly the opposite to what you've just articulated. We are looking at an internal career escalator. So, for example, if you join the ambulance service, either as patient transport services or the 999 service, you can actually have a pathway that you can see that you will be able to access that will take you, if you wish to, go all the way through to paramedic and specialist paramedic, and maybe even beyond, because we are looking at the role of advanced paramedic in the future to help with that skill mix and that senior clinical decision making. So I hope that that reassures you that far from diluting further, we are trying to enhance that registered role within the organisation. And also looking at different skills. As a nurse, when I go out, I know that I can do certain things with my registration that paramedics can't. So we're looking at a blended approach to try to meet the growing needs, certainly of the urgent care population. So I hope that goes some way to answering those three questions.
Okay, thank you. I've got Councillor Wood next, please.
Thank you, Chair. Not so much a question, but more a comment on the lost hours during handovers. I think there's a much bigger story than just the data itself. Paramedics are really attentive, they ensure patients are comfortable when they reach a hospital, and they do build personal relationships, explaining to the patients what will happen next. And I think for more vulnerable groups, such as the elderly, who might be visiting alone, the interaction can really change the experience they have at the hospital. So it's a lot more than just handing over paperwork to the hospital. So I just wanted to say thank you for the work you and your team do, and thank you for your report.
Thank you, Councillor Wood. Very much appreciated.
Thank you. I've got Councillor Morgan next, please.
Thank you. First of all, thank you for the report overall, which is very comprehensive. But on the performance figures, where you can see category 2, but what's the situation with category 1, which are the most life-threatening? That's my first question. The next one is, we're becoming more and more dependent on early assessment of patients' needs. Where should they actually be going? What quality assessment are we doing regarding the decisions being made on the front line to identify that we're actually making the correct decisions there? Because I have had some patient feedback where people actually have been referred to places and ended up having to go around in a loop and in fact were incorrectly diverted. So I just wonder what measures we're doing there, because that's so critical given the situation. And on the staffing front, you mentioned the older staff. Just a great deal of sympathy with that one myself. But what percentage of staff are actually, shall we say, over 50, over 55? Shall we see how big the potential issue actually is and the impact it might have? I noticed you've got figures for Lincoln and Boston regarding turnover times, but we were assured when Grantham lost its A&E and had an air quotes enhanced urgent treatment centre that there would be emergency support and sustaining patient life there. So what's the relationship now between EMAS and Grantham Urgent Treatment Centre, and what are the performance figures looking like there? Thank you.
Thank you, Councillor Morgan. And thank you for your comments on the report. I'll hand over to Neil in a moment. He'll be able to give you the category 1 response for the division. In relation to the quality assessment on the front line, we have a range of senior clinicians who work 24 hours a day. So we have 4 duty commanders a day who are experienced paramedics, and we have the clinical leadership team as well. And what we are doing to ensure that particularly the newly qualified individuals, when they are on scene with a patient, we actually do contact them to make sure after a certain length of time that they are okay, that do they need any additional support, do they need any further clinical advice, and we either give that clinical advice through those senior clinicians or refer them elsewhere. So we're not always able to do that, but there is quite a robust level of scrutiny on staff when they are on scene from a distance. They all have radios. We do what we call point-to-point, so the radio contact is there, so that is an immediate contact and not subject to mobile phone signal issues, etc. So if there are any issues that you refer to where you've got concerns that we haven't got it right, happy to have that conversation offline for specifics, if that would help. And certainly with regard to the figures on the more mature workforce, we can indeed provide you with those figures as well in a written report post-meeting. In relation to Grantham UTC, we have had specific oversight. Now the new eligibility criteria has come in because it is a bit of a cultural change for staff, particularly in the south of the county. So we have got oversight of patients going into and what patients could go there rather than go elsewhere, such as Peterborough or to Boston. So again, through that duty commander function that I've already mentioned, we are able to scrutinise patients who may meet that criteria and help and advise the crews attending that an attendance at Grantham would be appropriate given the circumstances presented. So again, it's work in progress, but we do have scrutiny on that. And to my knowledge, we have had no significant issue with patient care since the new eligibility criteria came in.
I've allowed you 4 questions there, Councillor Morgan, so if it's very, very brief, I'll allow you to come back.
It would be useful in future if we could have some sort of understanding of the volumes. It would be very helpful in future if we could have some report of figures around the numbers of patients being referred to the UTC via EMAS, if that's possible.
Yes, we can include that in future reports, definitely. Yes.
Okay, thank you for that. Moving on, we've now got Councillor Cleaver, please.
Thank you, Mr. Chairman. A couple of things. Thank you for the report. I'll echo the comments of my colleagues that it's always good to see something that is so thoroughly well written and covers off so much information. On your section about recruitment trajectory, figure 21, I note that there are some very optimistic figures there about November, December and January recruitment. But they are actually projections and not actuals. Given that we're now in the 3rd week of January, do you know whether that very ambitious figure for November and December were actually achieved? That's my first question. The second one is I was interested by the comments that you made regarding emergency planning. And this is fresh in our minds after Storm Henk, which affected us quite a lot in the south of the county. which we're not usually used to being the most affected part of Lincolnshire when there's flooding in South Kesteven, but we were this time, and so it's fresh in our minds. And I wondered, in terms of EMAS's emergency planning, what level of detail you're already aware of regarding the number of vulnerable people that might need to be evacuated, particularly from care homes and from local authority sheltered housing, which we have in flood-affected areas. So, for example, when a flood alert is declared, do you already have in front of you all the addresses at which are care homes that might be liable to flooding, and therefore able to respond quickly if called out? Yes, those are my two questions. Thank you.
Thank you, Councillor Cleaver, and again, thank you for your comments. So again, in reverse order, so do we hold lists of vulnerable people? We physically do not hold those lists, but that's where the Lincolnshire Resilience Forum comes in. They do hold those lists, and that's why we work very closely with them and train with them. So the scenario that you have just described, we would not be involved as a 999 emergency service in evacuating a care home that was under threat of flooding. There are business continuity plans, both by care homes and local authorities, that would detail, should that be required, what the evacuation process and method would be. Obviously, if that was an emergency situation, then yes, we would work with colleagues to make sure that patients remained safe. However, as a business continuity issue, we would not ordinarily be involved, because that would detract from our ability to respond as an emergency response, because unfortunately, while flooding and these issues occur, normal business does not stop for EMAS. So hopefully that gives you some assurance. So the business continuity plans outline what colleagues would need to do under those circumstances that you describe, but we are always in the background, and the vulnerable people's list is held by the Resilience Forum, and they set up various cells for people to have oversight and dedicated input into elements of any emergency situation. The figures on figure 21 for November and December, again, I will actually, my understanding is we did achieve them, but I will confirm that again in a post-meeting written note.
Thank you very much.
Thank you. Just before I bring in my next speaker, I think it's probably a good time to ask the question, because it follows on from Councillor Cleaver's. So Storm Hank led to 2 bridges in and out of Lincolnshire actually being closed for several days. So how did this actually impact the ambulance service?
We work very closely, Councillor Macy, with the Highways Department 24 hours a day. So we have workarounds, and indeed, you know, sometimes we are allowed through. I'll give you the example of day before yesterday, the Humber Bridge was closed to all traffic, apart from ourselves, and we could go over at 10 miles an hour with escort. So we are given priority. We work very closely with Highways, and they're linked into our emergency operations centres at Nottingham and Lincoln with alternative routes. And we also have alternative ways of getting to people with different types of vehicles if absolutely required.
Thank you. Okay, Councillor Parkin next, please.
Thank you, Chairman. A lot of my questions about the immediate situation have been answered. So I kind of want to move for that case to that case for change. Because we're looking at quite a substantial change of ethos and purpose for the ambulance service, which I don't necessarily disagree with. But at the moment, what we've done is a really, really good job of steadying what was a very turbulent ship on very turbulent waters. And I think everyone involved should be genuinely commended for that. But we are still not back in any means to a perfect world. And looking at the data, looking at where we are, it wouldn't take a huge amount for us to wobble again. And we are breathing a sigh of relief that what we've got is stability as opposed to further deterioration. And I do not for a second underestimate the amount of effort and commitment from everybody that's gone into that. But my concern is we're still looking at a service that is quite vulnerable, and we're still looking at a service that is being asked to accommodate another raft of changes. You can tell where we're going with this question is, are you worried about that? Do you think we're in a position where we have stabilised enough that we can accommodate another raft of what will be quite substantial change without it impacting on our patients?
I see exactly where you're coming from, Councillor Parkin, and for me, it gives a level of opportunity. So if I just take us back, so we are saying that our Category 2 performance has improved, and we're looking at just over a 30-minute to 36-minute response. That's double the national ambulance target. So we're still a long way from where we need to be. Sorry, I'm going to have to drop off again in a minute because they're setting up an urgent call with regard to the platform here. So I'll just finish this one, Councillor Macy, and then I'm really sorry, I'm going to have to drop off, but I will leave you in the capable hands of Neil. So Councillor Parkin, just coming back to that, for us to sustain and improve further and to have that stability that you describe, that's what we're all striving for. I see opportunities in that document and the way that we're working with the ICB in particular and our system partners, because that's the only way. Changing how we work is the only way that we are going to get that stability that we're all striving for. So I will keep you updated on how we're doing that and how that's working through. But certainly there is a huge commitment from the management team in the Lincolnshire division to bring about that change that is much needed to then give that greater stability.
Okay, thank you, and thank you, Sue, for your attendance. Obviously, we'll hand over to Scott to continue.
Yes, I'm really sorry. Thank you very much.
Thank you. Okay, I've got Liz next, please.
Thank you, Chairman, and obviously thanks to Sue and Neil for their report, and really echoing the quality of the report and the work that's been done. From a Health Watch point of view, we're kind of interested, I think some of the councillors have mentioned the patient experience in all of this. And I can't really see anything in the report that kind of focuses on the staff experience, but not necessarily the patient experience. We know from Health Watch that there are sort of some complaints that we've had in which we've fed back to EMAS, but also equally, and probably overweighing the amount of complaints, is the number of compliments that the service are receiving that we have had. So I just wonder from Neil's point of view, in terms of our EMAS in our local area seeing the number of complaints reduce and the number of compliments go up, or is that just something that as a local Health Watch that we're seeing? Thank you.
So in terms of that, I think you've painted the picture exactly there. I think what was echoed in our CQC report is also what is reflected in public opinion. Our CQC report effectively said, and this was quite a little while ago, that there is delays in EMAS responding. However, the care that patients receive is excellent, and the quality of patient care delivery when we get there is fantastic. And that is equally reflected very much so in our complaints, in our PALS interactions. The vast majority of complaints that we've received over the past calendar year, say, is around delays, is around expectation of when people want a response and deserve and justifiably need a response versus what that response looks like. Very, very limited and low numbers is actually about the care delivered, the care received. It's predominantly delay driven. Now, we have seen a significant increase in that because it exists with a degree of time lag. So all of that increase in delay that we saw sort of September into October is now reaching the point of conclusion and reply through, say, November and December. But I'm hopeful that will continue into the future as the primary issue in the forefront of the public's mind is speed of response, and that's something that we're actively working to improve. So I'm hopeful in the future that will very much reduce as well.
Thank you. My final speaker is Councillor Martin, please.
Yeah, thank you, Chairman. Just a couple of quick questions, actually. I noticed on section 2.2 where it says AACE believes that, and it has some points in there. It says, frontline clinicians now all have individual iPads in order to support pre-hospital clinical care delivery. My question really is, what actually do the iPads do? And when it says frontline clinicians, I presume that means like the ambulance teams and such like. So that's one question, is what actually does the iPad bring? Is it data, GP information and that kind of thing? And the other question is, it goes back to patient experience. I know when the lives first responders come out before the ambulance teams, when they've done their thing and they're leaving, they leave like a card which says live first responders, got information, details and such like about feedback and how to actually, what the service was like. I just wondered why we don't receive any of that kind of thing from the ambulance service. There's no actual option handed to patients and saying, here's some information, or even where your relative may have gone, say as an elderly lady and her husband's been taken off. It would be good if at some point that elderly person could be given some information, reassurance when the ambulance team leave of who to contact, because at the moment I don't believe there's anything like that available.
Certainly. So to answer the iPad question, first of all, so the iPads that all our staff nationally have been given has been a real game changer in terms of access to information and assistance with decision making. So it covers a multitude of areas. It is primarily the means of doing our electronic patient report form. So in effect, recording all the actions we've taken during an incident. That's then transmitted to the hospital. It becomes part of the patient's notes there. In terms of what it provides for information and awareness, it allows our staff to see the patient's electronic NHS wider record in terms of recent interactions they've had, medications, allergies, recent letters from hospital appointments, consultants, recent blood test results. It provides access to all of the pathways that are available, be that virtual pathways, in-person pathways, telephone helplines for clinical decision making. So it aids them in that what is the best option for the patient. It provides data around how they do their job. So, for example, you can look up medication, doses, interactions, individual pieces of equipment that, maybe something you don't use regularly and you want to know, for example, what's the weight limit on this hoist, for example. It also fundamentally provides a rapid access to, thankfully, some of our lesser used reference material and interactive tools for things such as major incident management, emergency preparedness. It provides aid memoirs for that sort of thing. So it's very useful and a real game changer in terms of keeping things current and up to date, because of course it's all online based, it's all electronic, so there's no book in your pocket that's going out of date needing republishing. In terms of the lives question, absolutely yes, lives do leave a feedback mechanism, I suppose you would call it, and I don't believe that any other ambulance service does. We certainly don't at EMAS provide a how would you rate our service type card. What we do provide is, through various other mechanisms and interactions, the ability for people to provide retrospective feedback. And we do things such as the Friends and Family Test, which is a national mechanism for feedback in terms of service users. We do periodically do with a degree of screening of the calls, and I'm sure you'll appreciate some calls you wouldn't want to be interrupting people to go back over what is for at times the worst day of their life, but we do provide a screened version of retrospective phone call to say, how would you rate this and do you have any comment you wish to give. In terms of what we provide people on scene, if we're discharging them in their home, for example, we do provide a leaflet in effect with follow-up advice and a description of what's happened. We don't provide a documented, this person has gone to X hospital. We do ad hoc if it's something that would be useful and provided on a case-by-case basis, but it certainly isn't at present a standard approach.
Okay, thank you. I've just got a couple of questions myself, and then I'm going to move to the proposal. So my first question is, do you see the changes proposed by the Humber Acute Services Review further adding pressure onto EMAS, with longer journeys being needed for ambulances in the west of the county travelling across to Grimsby? And if so, how do you plan on mitigating against this?
So while I'm aware of the Humber Acute Service Review, it's not a piece that I've been extremely close to. However, it does follow the form and function of previous acute service reviews. So whenever these reviews come up, we are an integral part of what that looks like and the planning for it so that other parties are aware of the risks and mitigations. And so what I know has been done is modelling of if hospital A moves from location to location or the service changed, for example, stroke or A&E service delivery changes, that's been modelled using effectively a national expert agency who does ambulance service modelling to say if this change occurs, what amount of resource would need to be put into this area to mitigate that change and keep patient response, patient safety, performance at the level it should be at. When we did this historically with some of the moves within Lincolnshire, for example, when we had stroke services moving around within ULHT, we did a very similar degree of modelling and we're able to make commissioners and other agencies aware of what the resource implications of that would be to balance it out. It's the very same approach that would be taken in the Humber area.
Okay, thank you. And the clinical strategy refers to increasing hear and treat and see and treat with more resources allocated to them. Does the clinical strategy have a target for each of these ways of reducing conveyance to emergency departments?
So the hear and treat, to just answer that piece first of all, is twofold. With the move to NHS pathways, as we've done in October, that comes with it and needs to increase that clinical element of the control room to provide both the safety netting and the expertise to provide that enhanced hear and treat element. In terms of, I think if I understand the question correctly, what you're asking is, what is the future trajectory for EMAS from a hear and treat and a see and treat point of view in line with the changes in the clinical strategy? Apologies for that. I'm going to have to take that to a written response.
That's fine, thank you. And my final question is, does the Mental Health Urgent Assessment Centre at Lincoln County Hospital benefit EMAS, for example, by releasing ambulances more quickly?
Absolutely. The MUAC, to give it its abbreviated term, is hugely beneficial to what we do as an ambulance service. The benefit when you're looking at a report like this is quite clearly good because it releases ambulances quickly because there's not typically a queue, there's not typically a busy A&E department. But the one thing, of course, we don't want to forget is it's hugely a better experience for the patient because as a person experiencing a mental health crisis, being in an A&E, busy A&E waiting room is not a great environment to be in, and our staff are much prouder and happier to be delivering that patient to an environment that is much better for their well-being and outcome and clinical need, and through their eyes they would see it as a secondary benefit that they're not waiting in a queue, but absolutely from a performance point of view it's a huge benefit as well.
Okay, thank you very much. Well, please pass on our thanks to Sue for her attendance and for yours as well, Neil. It's been very, very useful. I'm now going to move to the proposal. I propose that the higher rate of hear and treat and see and treat in Lincolnshire continues to be continued, that the ambulance hours lost as a result of hospital handover remain a concern, but the committee recognises this is a health system issue where the East Midlands Ambulance Service performance is dependent on the patient flows in the system, and to commend the work done to reduce the waiting times. And finally, that we have a further update received in 12 months and also a written response in regards to the staff survey. So I have a seconder for my proposal. Councillor Linda Woodson. All those in favour, please show. Thank you. That's supported unanimously. Once again, thank you, Neil, for your time. We'll now move on to agenda item 6, the non-emergency patient transport service. Just Councillor.
Thank you, Chairman. Before we move on to the next item, I wanted to raise an issue that, for clarification and maybe your view about future work plans. It sits at the side of the report we've just heard, and it sits at the side of your very last question that was put to the presenters. And it's to do with the sort of forward view, I suppose, of what's been put forward this time by our presenters in terms of using ambulances to effectively take hospital services to the patient, rather than taking the patient simply as a matter of course through to the hospital. And we've heard that it's been moved in that direction because it's a more effective way of the use of the ambulance as a mechanism almost, because it helps them reduce response times and eventually maybe start meeting targets for those cases where they actually do have to take people into hospital as a matter of course. And I wondered, there were two things that came into my mind as a result of that. Whether we like it or not, I mean, the ambulance service is a private sector delivery. And if we are moving hospital services into the ambulance service to deliver under that private contract, it is going to be a private contract delivery of that service. We tend to ignore that because it's a white vehicle with flashing lights on the top. But that is the case in point. And there are reports of other services, particularly optometry or whatever it is, eye care, moving into the private sector through the high street providers. And we all know other things have taken place in that one. What I'm not sure of is this something that's been promoted solely by the EMAS as a way of improving their service delivery within the contract? Or is it something that is actually supported or even promoted by the NHS itself? Because I think that would be an interesting thing to know. And is this something that's solely associated with the EMAS? Or is that something that's taking place nationally within all the ambulance services? And you can see what I'm getting at. You know, how much of the NHS services is being put into the private sector through these sorts of initiatives, and where's that going to lead us in the long term?
Thank you, Councillor. And what I would say is I did close the debate down and we're going back to the item. So I think ideally if you can try and pick it up, I'm not sure. I think Neil will still be here for the next item anyway, I dare say. So I'll allow him quickly to come back in, but I am conscious of time and we have got the Home Office from 12 o'clock and obviously I want to ensure that we're on time for them where possible.
Which is why I wanted to raise it outside that particular item if at all possible. Is it a future work item or something?
Yep, certainly, and that's what we've got the work item at the end for, so we'll try and pick it up in there and we'll leave it and move straight on if I may. Okay, so agenda item 6 please, the non-emergency patient transport service. This item was circulated as part of the agenda pack on pages 79 to 93 and I'd like to welcome our presenters via Teams. Unfortunately Sue's obviously had to step out, but Joy Weldon, Head of Non-Emergency Patient Transport for the East Midlands Ambulance Service, Tim Fowler, Assistant Director of Contracting and Performance for NHS Lincolnshire's Integrated Care Board. If I could ask you to present the report in about 5 minutes, we'll take it as read and we'll take questions at the end, please.
Thank you, Councillor Macy. Yes, I'll start by presenting the report. Joy is with me, so when we get to questions, Joy will obviously pitch in and help me answer any of the questions that come up. If I can, I'll take the report as read. If my voice goes a little bit off, apologies. I've got the bug that's going around at the moment, so apologies for that, but please bear with me. So if I have to stop and cough in the middle of it, I hope you'll understand. I think the story of patient transport in Lincolnshire is well known by the committee. We had a previous provider we went out to procure back in 2021. We awarded the contract to EMAS after a long process of evaluation of bids. EMAS started the contract on the 1st of July 23. They've been in place now for a little over 6 months. We did mobilisation with EMAS in 2 phases. The first phase was effectively a keep the wheels going, keep the wheels, no pun intended, keep the wheels going round as a lift-in shift. That phase went really well. We are now getting into phase 2, but in phase 1 of the mobilisation, as we'd expect, we had a couple of teething problems. But working with EMAS, it's been really helpful in the way that EMAS have responded and helped us and set out to resolve those teething issues. So in the first month, there were a number of issues in terms of contacting the call centre, long times to contact. That's been largely resolved now. We've still got 1 or 2 little issues on odd days. Some issues around renal transport, which again we have worked with EMAS really closely to resolve, and EMAS have worked really closely with the renal unit to resolve. So on the whole, my interpretation of this, my impression of this is it's gone really well as a mobilisation. These mobilisations are quite complex to work through. But because it's gone so well, we're now moving into phase 2 of a mobilisation, which will see us extend the number of bases that EMAS operate out of within Lincolnshire. And that's good for patients. It means that vehicles will be able to get to patients more quickly. It's also good for our green agenda. It means that we'll be able to increase the use of electric vehicles, and that's a good thing for Lincolnshire. So I think generally it's gone well. The feedback we've had from the providers in Lincolnshire, from ULHT, is that this change has been able to improve the flow through the hospital and particularly the flow out of the hospital. And that's really good news. That's really positive news, and that's what we wanted. One of the objectives we wanted to achieve by reprocuring this service. We've also got good feedback from LCHS, from our community provider. We do have a stakeholder forum that we've established to get feedback from various parts of the system, the health system, and wider within Lincolnshire. And generally, the feedback that we've had has been positive. We changed the approach in the procurement to KPIs. I think the committee has a knowledge of the previous issues that we've had with KPIs being in patient transport contracts. We've moved away from having strict KPIs within the contract, and what we wanted to do was reflect better what's important to us as commissioners and what's important to the people who touch base with the service, so patients particularly, but also healthcare practitioners. And what we've done, we've put in what's called a local incentive scheme, where we want to give EMAS a responsibility for 3 key objectives that are important to us and important to patients. So that's zero tolerance of rebeds, patients going back into hospital because patient transport isn't available or can't turn up on time. The satisfaction of patients with the service and the satisfaction of healthcare practitioners, hospitals, community providers, renal unit, etc., with the service. And then a third one, which is delivery of social value. Within that, EMAS have set some kind of working principles, some delivery principles, and you may recognise those as being very similar to some of the KPIs that we had within the previous contract. And they're set out in the appendices. The performance of that is set out in the appendices to the report. I think that generally, there's still a bit more work to do on a couple of those. There's a narrative attached to that part of the report that sets out some of the issues that we've had, but it's ongoing work with EMAS, and we're working really productively with them at the moment. I hope that's about 5 minutes. If I leave it there and open to questions.
Thank you. Yeah, I've got my first question. Councillor Allen, please.
Thank you, Chairman. All my comments are based on the acceptance that we're at early stages of this contract. We're 6 months in, and I'm not totally sure whether we've moved into phase 2 or having completed phase 1. It may well be that's the case. You know, there's not an awful lot to say, I think, on the basis of the actual report and the information that's in front of us. So maybe it's a question of waiting to see how things go over the next 6 months as well. The internal targets that we've got, you know, and whether a performance principle is a greatly different to a KPI or not, I'm not totally sure. But at least if it's got the buy-in of the contractor, that's something. But the internal targets have a good deal of leeway to start with in terms of what's been expected in terms of the delivery. And the table that we've got in Appendix B, I think it is, relating to the principles of delivery that are set out in A, indicates that probably quite good from our perspective that there's not been a cliff edge drop in terms of delivery from the look of things when the contract was taken up. A fairly linear, I suppose, delivery since then, from July to November. There's certainly some degree of variation in terms of how the internal target is being met, I think, which may be something that is receiving attention now as we move into phase 2 and actually look at improving performance and outputs. And I think that's really all that we can say at the moment, all that I can say at the moment anyway. Things look good in terms of we're not, I say, dropped off a cliff when the new contract was started. There presumably are some benefits in terms of EMAS running both aspects of transport. And maybe as we move into phase 2, performance will pick up and improve considerably, and that might be shown as in another 6 months.
Shall I try and give some comments back on that? To take the point about is there a difference between a KPI and a delivery principle? The way we've structured the contract is that we've got the local incentive scheme. EMAS have to demonstrate as the contractor, as the provider, that they are working to a local incentive scheme that includes patient and healthcare practitioner satisfaction. The delivery principles are an internal measure in EMAS that point towards whether they are going to deliver patient or healthcare practitioner satisfaction. So if I take the vehicle collection, sorry, not the vehicle collection, the patients being collected from their appointments on time, if they're not, it's likely that when we do the work to assess patient satisfaction, patients won't be satisfied. That will mean that EMAS potentially have a financial penalty. They lose some income from the contract. So that's how it works. So the delivery principles are important. There is no penalty attached to each of the delivery principles. But if you take a holistic approach to that, what then happens is that it measures and helps in ourselves as commissioners and EMAS have an insight into how patient satisfaction overall might work. So that's how we've tried to structure the contract in that way. And interestingly, this is quite a departure for patient transport services doing it in this way. And we are getting quite a lot of national interest. So the national PTS, patient transport part of NHS England, is asking us to write up a case study on this. And they've also put us in contact with a number of other areas that are looking at how their patient transport services work. We're not quite there yet, but it is a new departure, and we think it will work really well. It's about supporting that partnership. When we set this contract, it's a 10-year contract, 9 years, 9 months. What we wanted to do was have our provider as an integral part of system delivery within Lincolnshire. having EMAS as our patient transport provider allows that greater synergy between what the patient transport service does and what the 999 service does. It also provides the opportunity for a career path for individuals who join the patient transport service and then may want to progress through to the 999 service. So from a Lincolnshire delivery point of view, it's a real positive that EMAS are in place. I don't know if that helps, Councillor Allen, but hopefully that gives a bit of insight into what our thinking was.
Well, it certainly does. I mean, any contract that's got financial incentives in it to achieve performance delivery, whether that's by internal targets or KPIs, I think is a very good thing. And it's it's probably the very reason why there's so much attention being put onto the contract and how it's going to operate by others. So it's no bad thing. I think I did recognise the benefits of having EMAS providing both aspects of the service that moves patients around Lincolnshire. Just one other question, I think, and this is to do with the success of the new form of the contract that you're operating. Is there anything that you can provide, when you do report in the future, that shows how better we are performing in relation to the contract and the EMAS delivery compared to other service deliveries in the East Midlands area or even nationally? Because at the moment, the way that the report's written, it's very difficult to identify that.
I might ask Joy to help me with that answer. My understanding is that at the moment there is no consistency nationally in terms of the performance targets that different ICBs have with their patient transport providers. There is a lot of national work going on at the moment to try and pull together some national data, which is then shared with ICBs, but that's more about activity rather than about the KPIs that the individual ICBs have. It is something that's being worked on at national level. So unfortunately, I'm going to have to say at the moment, the answer to your question is we can't pull that together. As that develops, I'm more than happy to. What I may do, I can talk to my counterparts in the East Midlands region, and see if they would be willing to share their KPIs and perhaps benchmark that way. But let me talk to them, and I'll hopefully be able to bring something back to a future session of the committee.
Okay, thank you.
Don't know, Joy, if you want to add anything.
No, just exactly the same. There isn't the consistency out there from one contract to another that would be able to provide a direct comparator.
Okay, I'm going to ask two questions now that I was going to ask later on, because I think Mark has kind of in the round been on a similar basis. But looking at the table on page 124, can you please expand on why performance is so low on 2.3 timely service for all patients, 3.1 excessive wait for 2 hours or more, and 4.1 waits of no more than 60 minutes for booked journeys? What's being done to improve these? And then similarly to my last question, but aimed more for yourselves as commissioners there, Tim, how do you view these figures? Because there are no KPIs in this contract, unlike the previous contract, how can you ensure improvements without financial penalties and with a much longer length of contract? Because being super critical, having seen years of the pain of Tassel, they started off on a similar basis and then just eroded and continued to go downhill from there. Not saying that it will be a repeat of that, but we want to ensure that stability for the residents moving forward.
Joy, do you want to answer the first point and I'll come in on the second one?
Absolutely. So regarding principle, for example, principle 2.3 is around where the below narrative just demonstrates there that the exceptions outside of the measure that we've put against ourselves is that we are also ensuring that patients are earlier or they're not too far outside within the agreed time frame. And so as part of the LID, so it works in conjunction with the LIS and the elements of satisfaction. And so what we're already undertaking is numerous surveys, numerous conversations with our stakeholders, our system partners, and patients, so we're already gaining information from patients to be able to review anybody who then falls outside of those parameters as to how we then start to look at making improvements or service developments. There also is the next phase of the mobilisation, which will also help us strategically have our vehicles across the county in a more strategic way. And so we'll be going from 5 locations to 11, which then reduces the amount of journeys that we're undertaking without patients on board, and so it improves efficiencies and effectiveness that way. And so over the coming months, we should be seeing some improvements in those areas.
If I can answer the second point, as an ICB, given the history of patient transport, we see this as really important that we have the right service delivered to patients. As I said before, we've moved away from the previous way of holding providers to account. So we used to hold HTG to account as best we could by having financial penalties in place for each of 12 KPIs which were in the contract. Gets into a bit of a circular discussion there, because if we put a financial penalty into a service that isn't performing, it really doesn't help performance. So what we've tried to do is move away and move from a penalty to what we would term an incentive. And as I said before, we've got a view here that the delivery principles are important. They give us an insight, they give EMAS an insight. But what's really important is this a good service that patients are receiving? And is it a good service that hospital practitioners are receiving? And if we put those two together, that's the key measure of the success of the service. And within that, we've got our EMAS being responsive to patients. Are they explaining to patients? Are they communicating with patients? Can patients get a response when they call the booking line? How long does it take? Are hospitals feeling that it's a good service? So is flow being supported not just at ULHT but in our peripheral hospitals? That's really important. That gives me much more insight into whether the service is successful than having individual KPIs. We do still have monthly meetings with EMAS. I think it's still early days in the journey that we're going on with EMAS here, but we are at those meetings, we are reflecting on the performance and we're asking EMAS to pull it up. But the key measure here of success is the local incentive scheme rather than the individual KPIs. Don't know if that helps.
It doesn't, in fairness. I think the reality is it's a very short report as it is, and there is nothing whatsoever in this that says about patient satisfaction. So although we're probably not hearing the noise in the system we were previously, there's nothing to back that up and say, well, actually, you know, from the patient's point of view, this is now a far better service. And I think that information will be hugely useful when you do start looking as a state, those particularly low areas of performance. So I think that would be useful to come through to the committee as a separate document, obviously, if you can, please.
Joy, do you want
Yes, sure. So we have, in addition to the contract meetings, monthly quality meetings, and as part of that, the information from all our surveys are captured within that. So we've already started to have that feedback, both where we can make improvements and actually areas where we're doing really well. So we already have those discussions, and so there's absolutely the information there to be able to put that together and share in that way.
That's useful, thank you. In which case, I'll hand over to Councillor Morgan next, please.
Thank you. One of the things that strikes me with our performance table is that it's lacking for the actual numbers. It's all about percentages, so it makes it really difficult to really assess exactly what you're up against. Really, is, you know, if you've got thousands of journeys, then maybe we can understand a bit more. or is it just a few hundred? The figures are mentioned in the descriptions below are actually quite small, in my view. So I'd like to understand what the volumes are that you're dealing with. I think there's a gap, and I don't see it being addressed. And in fact, I'm concerned it could be even worsened. Certainly from our point of view, it's where patients have been referred to an A&E and then released. So they're no longer an acute patient, emergency patient, because they've come out the other end of the service, but they have no means of getting back to wherever it is that they live. Now, in the daytime, I suspect that there are mechanisms in place, but we're seeing particular issues at night time, and we've got to the point now, which is hugely worrying. We've got people paying maybe £80 for a taxi fare to get back because they've been released from the A&E in the early hours, and they have considerable journeys. A lot of our residents we know have a long way to travel now to get to their nearest A&E. It's all very well, for example, if you live in Lincoln, you're talking about a 4-mile journey or something, but for some people it's a 40-mile journey to get back to their home having been released. And I can't see in here that we've addressed that gap. I have to say, having raised it 10 years ago, I'm hugely disappointed it doesn't seem to have been covered. And in fact, I'm worried because on the background, page 120, in the 3rd paragraph, it looks like you're targeted to reduce those late night journeys. So where does that leave those patients, particularly those on low incomes who can't actually literally afford alternative means to get home?
Before I bring in Tim, I would say there is a regimental criteria I believe they have to work to that is actually set in situ, so they have to go within that. But I'll let Tim and someone try and expand on that.
If I can take the first point from Councillor Morgan in terms of activity volumes, we're more than happy to share activity volumes. There's no issue there. So we'll make sure that's either done as a supplemental or we can bring it to next time we're presenting to the committee. The issue about patients being able to find a way back home after they've been to A&E or from discharge from hospital is quite complicated. We haven't raised it in the report because this report is about patients who are eligible for patient transport, which is the point I think Councillor Macy was beginning to allude to. There is a very strict criteria for patients' eligibility for patient transport. And within the scope of this report, we're talking about patients who are eligible and who have followed that criteria. I think there's a wider discussion that is needed in terms of patients who are ineligible for patient transport. How do they get from the hospital back to their home, and particularly late at night? It's something that the ICB is aware of, and there are discussions in very, very, very early stages going on about how that could be supported better. However, the obligation of the ICB, our strict obligation, is to support patients who are eligible for patient transport. But happy to take that conversation back into the ICB and to try and progress it. But for the purposes of this report, this is about patients who are eligible for patient transport, not about the wider transport system.
Thank you, Chairman. I think that's something I'd be happy to pick up in the work programme in reality, because it does inextricably link to things like the acute services review, where we did raise our concerns with how people would get home and so on. It's just probably not for this particular point. But do you want to come back, Councillor Morgan?
Thank you for that, but to both of you. Can I just clarify, because actually it would be, again, going back to the report, it would be really useful, because you refer to other documents, to have those eligibility criteria within here as well, so we can understand a bit more about, all I know is that I have, just to give you one example, a resident who had an amputation, who was on benefits, who was a pensioner, and she was left stranded. And to me, if that person's not eligible, who is? But you know, it does make me wonder what the criteria are. Thank you.
So more than happy to share the eligibility criteria. I think if there are individual issues, such as the one you've raised, Councillor Morgan, again, more than happy to look into that, but without the individual detail, it's difficult for me to comment here.
Thank you, Tim. Okay, I've got Councillor Smith next, please.
Thank you, Chairman. And it partly goes back to a point you were raising, because call me a cynic. A KPI is a definable outcome. You are defining what you expect from somebody. A vision is very wide-ranging, and to an outside person looking in, sounds quite woolly. I will be blunt. That if you say a vision to me, that can be anything you want it to be. And this will be the first contract I've ever come across, Chairman, where there is no financial penalty for poor performance. You have a carrot, which is, if you do well, we share in the benefit of that. If you don't, the stick comes out because you aren't doing what you're supposed to. Now, I accept what Tim is saying, and I'd be very interested for this to come back and see how this progresses, because part of my concern is, how are you going to hold the patient transport side of EMAS to account when actually the normal means of an ICB doing that is through a financial penalty, is through a contractual penalty. If you're saying you don't particularly have those, you don't have much in the way of leverage to hold them to account in a manner that hurts. If you're wanting to hold a company to account, you hit, as the old saying goes, you hit them where it hurts, which ultimately, whether we like it or not, is the wallet, Chairman. So I'd very much like this to come back. And I appreciate it's not for this report, Chairman, but it needs to be said. This is something we have raised, as you said, for the acute services review. This problem is not new. My great-grandfather, God rest him, many, many moons ago, when I was still a small boy, had this problem of he was discharged late at night. He had dementia. He had no means of getting anywhere. He couldn't use public transport. And it was, well, someone's going to have to come and get you. Only we weren't told till 1 in the morning, and he was discharged at 11 o'clock at night. This problem is not new, Chairman. I had it here in Lincolnshire with somebody. I knew they were going to be discharged that night, very, very late, because of what it was. So they went in the ambulance. I drove, because they were needing assistance, but they were talkative. And I went in my own vehicle, and I drove them back. But if I hadn't done that, if I'd have gone in the ambulance, which normal instinct would say, you hop in the ambulance, we would have been stranded at Lincoln County Hospital, and they needed to get back to Gainsborough, and I needed to get back to Market Raisin, Chairman, which would have been exceedingly expensive by cab. So I certainly think that's something that, if we can give that some more scrutiny, Chairman, as you said, through our work programme, we need to, because this has been, shall I say, on the minds of commissioners for a very long time, and various promises have been made and said, and I appreciate what Tim is saying, that actually, strictly speaking, it's not an ICB responsibility, but it's got to be someone's responsibility, because it's not fair to say to the pensioner or to somebody who's not in that position, oh yes, you can afford about £120 to do a 20-mile journey back to Market Raisin, which is roughly probably what it'd cost you now, Chairman, and that's for anybody, whether you're on benefits or not. If you're not in shall I say, a fortunate position, that's a lot of money, whichever way you cut it, Chairman, and that's simply not an acceptable solution to say, we've solved your problem, now you can get yourself home. Really, that's not good enough, Chairman. No, I appreciate it's not for this report, but that absolutely needs to be said.
Yeah, once again, I'll just reiterate, we will pick it up outside, but the reality is that the ICB might not be responsible for the transport. Nevertheless, they are responsible for moving hospitals around and making people travel further. So that is the actual reality there. I don't know if you want to come in any further on that, Tim.
I won't come in any further in terms of the issue of how do patients get home from hospital if they're ineligible for patient transport. I will come in further on the issue about KPIs. I take the point that KPIs have been a feature of all NHS contracts for a long time, and have been used as a stick against providers. I think we're moving away from that, and national direction in the NHS is to move away from that and to be much more an approach where we work in partnership and collaboration. The best way of telling whether that partnership and collaboration is working is to measure whether patients feel they're getting a good service or a poor service. there is a financial penalty, a reduction in income that EMAS will endure if they do not deliver that strong local incentive around patient satisfaction, around social value, and around zero rebates. So we were trying to break the mould a bit. The history of previous patient transport contracts and in other areas is that the KPIs have been not really something that's been able to hold the provider to account. So we're trying to change that. We're trying to break the mould a bit, which is why we've got the national interest. And some of the colleagues that I talk to in other areas of the country, they think that this is a good way of working. So we'll wait and see. It's early days yet on the contract. I'm optimistic. I may eat my words in a couple of years' time. I hope I won't. I'm optimistic that this will work better than having strict KPIs where there are penalties applied if one patient waits 2 or 3 or 4 minutes longer than the target we've got as a KPI. Patient may be happy to wait 2 or 3, 4 minutes, get over that. It's getting that meaning behind what the service is trying to do. And I do think this is a better way of doing it. But more than happy to come back and report on where we are with the patient and the healthcare practitioner satisfaction at a future meeting.
Thank you for allowing me to come back. I look forward to that, Tim. The only thing I would say is if penalties are not working around KPIs, is that not a failure of how a contract's been drawn up rather than actually a failure of a KPI? And that's not a swipe at the NHS, that's all contracts that are primarily public sector contracts. I can think of many national contracts where the shoe's been on the other foot, and basically things have taken place because actually the penalties have been so strong that actually the government have gone, no, we'll carry on with this. An example is basically why we have a second aircraft carrier. I won't bore you with the ins and outs, Chairman, but needless to say, it would have cost more to mothball than to actually build the thing outright. That is a strong contractual penalty. So is there not a case of, and I'm not saying don't do what you're doing, I look forward to seeing if it, and I hope it does work, but as a more general point, is there not a wider issue in NHS contracts and public sector contracts on a, shall I say, a larger level, not so much, say, for us in Lincolnshire where we're concerned as a county, I think we do that very well, but on a much larger organisational central level, that actually our penalties that we've used in KPIs have not been crafted in the right way and not been sufficient enough in certain circumstances, so they actually haven't worked because the provider's gone, oh, it doesn't really matter that I've impinged on this KPI. I can afford to absorb it basically, and then as you've alluded to, some of them are too strict. So you go from one extreme to the other. You go from an overly rigid KPI to where it's overly strict to a KPI that's too lucid and not strict enough, and actually the penalty's not strong enough, and that's an issue of contractual draw-up rather than a KPI not working. But as I say, I look forward to seeing how this progresses and hope I eat my words in a couple of years and this works.
I wonder if it would be useful just for Joy, could you give a little bit of input here in terms of what the EMAS view of how we've changed the contract is and whether you feel we're being soft on you? I don't think we are.
No, absolutely not. And in conjunction with the service delivery principles, they're in place, so they're a measure. There's something that we can see. They're also there to be able to manage expectations, so that we've got something and a framework for patients and stakeholders and our teams to be able to deliver against. But actually, the biggest challenge, particularly in the incentive scheme, is the zero rebates. And that's a really key factor to be able to work through. So that not achieving that is a failure of that incentive scheme in itself. And to be able to support and manage the discharge activity within the system is really challenging. However, a really key area for us to work on, because that also then supports our A&E colleagues in what they're trying to achieve. So it's a whole system approach, and so we're absolutely, from my perspective in particular, don't feel that this is any change in terms of being held to account, which is what's important, but actually it's really focusing on what is it that patients need, but ultimately also what is it that the system needs as a whole to be able to to maintain patient flow throughout, and that zero rebed is a key area to deliver on, and so it's really important for us to get that right.
Okay, thank you. I'm just going to ask one final question and then I'll move to a proposal. On page 121, it refers to volunteers continuing to be part of the service delivery. How do local voluntary car schemes fit into your arrangements now?
So we have our own, and so we have our own car scheme, and we've as I alluded to in the paper, that we have some more volunteers joining us at the end of this month, and that's a real big part of our team, that we continue to grow volunteers, and that for us as EMAS is really important. We have two other areas, particularly within PTS, that have the same want and desire to grow the volunteer teams, and it's really important for patients who are reliant on PTS a lot, particularly renal dialysis patients going to oncology. So they see that that regular service, the regular patients, but also it offers a real value for the volunteers themselves. And so the more accessible we make that for people of Lincolnshire, for me, I see that as a real community drive as well, in terms of engaging the sector and growing that. So yeah, it's really important to us, and we're already starting to see that develop and change.
Thank you, that's hugely positive to hear. In which case, I would like to thank our presenters for attending this morning and make the proposal that the current performance by East Midlands Ambulance Service against the service delivery principles be noted, and the committee's desire for improvement to meet the delivery principles be recorded. I'd also like to request a copy of the patient feedback and details of the criteria be provided, and that we request a further update in 6 months' time. Do I have a seconder for my proposal, please? Councillor Wotton. All those in favour, please show. That's supported unanimously, thank you. Once again, thank you to our presenters. We'll now move on to agenda item 7, the impact on NHS of proposed use of former RAF Scampton site for asylum seekers. This item was circulated as part of the agenda pack on pages 125 to 127. I would like to remind you that the remit of this committee is NHS healthcare. Therefore, I would ask that your statements and questions on this item do not stray too far into any other public sector service, as that is outside the remit of this committee. The report has been prepared by NHS in Lincolnshire, however they were unwilling to present this, and we have a representative from the Home Office in attendance. Hopefully he should be here with us now. Simon, is he?
Chairman, not yet on the call. We've got a minute or two before midday when we are expecting
him. He is due at 12 o'clock, so we'll just hang on for a minute or two. Yeah, Councillor Morgan.
I know it's a little bit late, but I should have said it really before. With regards to our previous item, I do think we should be thanking, because like the emergency services, the guys, especially as we're relying on volunteers as well, they are doing a really good job actually on the ground, and I just think that's where we should recognise that.
Yeah, absolutely. I'm happy to take that on board, Councillor Morgan. It goes without saying that we've always been hugely supporting of the volunteer car drivers and those that volunteer for the service. It was one of our main issues we had with the previous provider, who unfortunately did not treat the volunteer car drivers particularly well, and a lot of lessons I think have been learned from there, so I'd absolutely be happy to reiterate that support for them. So thank you. Simon,
we're still waiting. Could I just say that I have picked up for the work programme the comments that were made by Councillor Allen and by Councillor Morgan. So the issue of the criteria for, when the criteria are sent round on an email, you'll find that they are quite strict and are limited to medical needs. People who on low income are directed to another scheme, but there are still, aside from that, wider issues on patient transport, out of hours, you know, when bus services may not be running, if someone is discharged from hospital late. So I've noted that, and also Councillor Allen's comments about the, if you like, the direction of the ambulance service in the future. One of the things that I know wasn't, the Appendix A to the ambulance report, although it is a national document, has been produced by the ambulance service chief executives. So it's not quite, well, say not quite, it's not national policy. It's not Department of Health policy or national NHS England policy. It is something that those chief executives are promoting rather than an actual fact. So I just say that in passing. And I'm trying to fill up time, but not very well. Thank you. I'm going to stop there.
Councillor Morgan.
Thank you. In that case, I made some comments on the previous. Yeah. Sorry, I made some comments on the previous item regarding what could be included in the report from on the emergency side, and I got the general sense that they were agreed with. I'm just checking that they'll be picked up as well.
Maybe for the next report.
Yeah, thank you.
I don't know at this point, Simon, whether it's worth doing the work programme in full, to be fair, while we wait, because if the gentleman's going to be too much later, I don't want to delay the meeting, and I don't think if we have a comfort break, it will work out too well.
No, okay.
So we'll move straight to agenda item 9, the work programme, and I'll hand back over to you, Simon. This can be found on pages 177 to 183.
So yes, the work programme is as set out in the papers. There are a couple of changes. If I ask the committee to look at pages 178 and 179, North West Anglia are now coming to the March meeting rather than February, but picking up from the work programme the item which is listed under the heading Pressures on Services at Lincoln County Hospital. That one is going to slot in to February, so we will have that as part of a sort of a general, I wouldn't want to call it a general update, but an item from ULHT on some of their key issues currently. So that's one of the changes. I do believe that the two strategies which are going to be presented as one item, but there are still two separate strategies, items 3 and 4, for February. I think that's all I need to say on the work programme at the moment. I don't know if any other members, if I've picked up, I'm not sure there's anything else that came during the course of the morning. Thank you, Chairman.
Thank you, Simon, for that. Obviously, other elements have been picked up, as Simon's already alluded to, just before we officially went into the work programme. Councillor Allen.
Chairman, I think Simon has got the issue that I raised during the course of this meeting, which is better methods of delivery of healthcare provision in general terms, using the EMAS example maybe, and particularly in relation to how that fits into the national picture and whether it is an NHS-driven policy. That was the issue, Simon. But there was another item that I thought might be useful for the works programme, and that was the current difficulties that we have in terms of accessing some of the important drugs that the NHS is supposed to be providing. My wife certainly has not been able to get what she's told are life-saving drugs since November, because the prescription cannot be delivered because the drugs are not being manufactured at the moment, and the NHS has got no other way of providing alternatives.
Yeah, thank you, Councillor Allen. It's something we discussed prior to the meeting, and I think it's something that's certainly worthwhile taking forward. It doesn't seem to be a one-off from regular conversations. It happens now across what I'm hearing, so I do think it's very worthwhile adding on, and I'm sure that will be picked up. Any other comments? Because I know that our presenter is now here. Councillor Morgan, if it might be slightly brief, just so that we don't go past for this gentleman.
Yeah, thank you. In view of the recent issues that we've had with flooding, it's kind of bringing to the forefront the impact of climate change, especially on our low-lying county. And I thought it would be really useful to have some sort of report back regarding what assessment's been done and what plans are in place should the situation worsen.
I think that falls under environment and economy, to be totally honest, and it wouldn't be under the remit of this committee. But Simon does cover that committee. So
the County Council's Flood and Water Management Scrutiny Committee, on which there are district council representatives, is in the process of setting up a working group to look at some of those issues. And one of the contributors at that working group will be the Lincolnshire Resilience Forum. So that should pick up some of the emergency issues in terms of, things such as Storm Babette and Storm Hank and the impact on the NHS. But I think it's more emergency services.
Okay, thank you, Tom. Just quickly, if you may.
It is very brief, Chairman. I'd certainly endorse what Councillor Anderson said. This is not a new problem. First it was because we've left the European Union, now it's something else. And I experienced this personally myself as well. And they say, oh, it's because it's the brand of medication you use, because I have to have that specific brand for my medical needs. This is not a new problem. This has been going on far too long now, and I think we, as a scrutiny committee, need to give this some very detailed scrutiny and hold in the individuals to account, because this is now almost every year now this happens, rather than, it was Brexit, then COVID, then something else, and now there's a shortage and nobody can account for why in this instance, and that's not the first time, Chairman, so I'd certainly endorse that.
Okay, thank you, Councillor Smith. I'm going to move forward. I think we're all in agreement with what's being taken forward, and of course anything else that's covered over the next two items will be picked up upon as a matter of course anyway. So I'll now move back to agenda item 7, and I would like to welcome our presenter, David Harding, Deputy Director of Asylum and Detention for the Home Office. David, welcome. I appreciate it is not your report, but do you want to say a few words on this item, or would you prefer we move directly into questions from the committee?
I can give afternoon, everybody. I can give a little bit of background if that would be welcome, just for a couple of minutes, and then take any questions if you like.
That'd be hugely helpful, thank you.
Okay, so I'll just whiz through some background. So in early 2023, the Home Office outlined its plans to utilise the former RAF Scampton site to provide accommodation for up to 2,000 single adult male asylum seekers between the ages of 18 and 65. Since March 2023, we've had significant engagement with NHS England, Department for Health and Social Care, and NHS Lincolnshire Integrated Care Board, so the ICB. And during this time, extensive work has been undertaken with local and national health partners to work through the specifics of the health care provision to be provided on the site, and really importantly, to reduce the impact on local health services, and particularly those living in the local vicinity. So we've worked through the healthcare provision with local and national health partners via a multi-agency forum, and we've got a subgroup of that, a health subgroup, which we've got specifically set up to look specifically about how we reduce the impact on local health services. The healthcare facilities on site, so we've made significant progress in the refurbishment of the existing medical centre on the site, and we've got medical equipment installed into this two-storey building, and the current planning assumption is that the ground floor will be utilised to conduct both health assessments on the day of arrival for service users, and then the first floor will be utilised for secondary or further appointments with the medical team. Each of those buildings will receive full compliance sign-offs before being handed over from our construction contractors to the site operator, which is Serco, and then on to the ICB. At present, there are ongoing legal challenges in progress between West Lindsey District Council and the Home Office with regards to Scampton. So there is no confirmed date at which the site will be ready for occupation. And in terms of funding, the Home Office have agreed a funding package with the ICB that covers both the setup costs and the cost for the year end. So in terms of inflow, we've got an agreement with the ICB that when we are ready to take inflow of people into the site, that we will do that in a very controlled way with regular pauses. So our plan at the moment, or our working assumption, is that we would take around about 30 individuals in a day, so no more than 150 a week between Monday and Friday, and that means that we can then review how the healthcare is administered as they come onto the site, how the induction works, and then how we eventually plan to ramp up the site. So hopefully that's a bit of background that you'll find helpful, and I'll hand back over to you to take any questions that I can.
Yes, thank you very much for that intro. That's very, very helpful. My first question comes from Councillor Wood, please.
Thank you. I've just got 4 questions, but they're quite short. Okay, so it says that medical facilities will be there, but obviously they'll be limited compared to what you would get in a hospital. So what happens if somebody gets seriously injured or ill and requires more comprehensive treatment? Will they then be taken to Lincoln County Hospital? How many medical staff will there be on site at Scampton, and specifically how many in the mental health team? Will we receive updates to the Health Scrutiny Committee if something goes wrong with the medical provisions on site, as we would with regular GPs? And how much funding is in that package? And if there are more pressures on Lincoln and the surrounding areas than you anticipate, will they then have access to that funding? Thank you.
Do you want me to respond now? Is that okay?
Yeah, I should have said at the beginning, Dave, it's a bit of a jumbled up system, so I can't always see you and so on. So yeah, if you just want to respond directly, that'd be great.
Don't worry, and I'm happy to take those questions away. I can tell you that the on-site medical provision will be somewhat in alignment with that we have at Wethersfield. So it'll be primary GP services. So it won't be anything beyond what you would normally expect at a local doctor's. So there will be referrals, if necessary, for more serious cases into the system. I know there is a provision for mental health, but again, the details on numbers of staffs and specifics around funding, I'd have to come back to you on. I'm sorry.
Councillor Wood, would you like to just come back briefly?
Yeah, did you just have the answer on how much funding will be in the package?
I don't know. So we do have a funding package agreed. Let me just check if I've got. We do have a funding package agreed with the ICB, and that covers setup costs, and it also covers a cost that's been agreed with NHS. So I don't have that to hand, so I can't comment on what that per person cost is at this point.
Okay, I think before we progress any further, Simon, I think it might be worthwhile for any of the questions that the councillors have asked are recorded down, whether it be that each individual councillor gets them across to us, and then we send them across to both David and to the ICB to try and get a thorough answer. Because I will just put on record, I do want to thank David for attendance, because we were outright refused from the NHS. So, okay, I'll move on to Councillor Allen next, please.
Thank you, Chairman. The argument seems to be that the medical and mental GP type services and mental health type services required at Scampton will be separately funded, and as a consequence of that separate funding won't have any impact on health provision locally or within Lincolnshire, which is absolute nonsense. Because unless we've got a whole series of GPs just hanging around at the moment waiting for the immigrants to start arriving, and similarly for the mental health specialists, it's quite clear that they will come from the existing provision that we have locally, which is under great pressure at the moment. And 30 appointments a day, which was referred to in terms of having a sort of structured delivery of the immigrants, is all very good, but we're lucky if we can get 30 appointments at 15 minutes each locally for our own residents, and they will be having 30 appointments with no doubt several hours. The resourcing that's going to be required is going to be demanding, and if any of that comes from locally, it's going to have impact on our own services, irrespective of the funding. The funding is a red herring in my view. And I hope the ICB will take that on board, Chairman, because it's really a question of them satisfying the needs and the requirements and the effects locally. So unless it's coming out of the private sector, all this resourcing, I think there's going to be impacts locally.
Okay, thank you. I don't think there's much further you could say on that one either, particularly David. As I say, if you do feel able to respond at any, just please do feel free to do so.
Yeah, no, I was just going to clarify that the 30 intake per day, they would that's the number that we believe can safely receive their full health screening, which is what they get on arrival. So those are appointments that are delivered through the service that will be on site. So there isn't day one, there isn't a draw on any healthcare in the wider community. That's all service from within the sort of GP provision service that we set up on site and paid for separately. The rest you wouldn't expect me to comment on. Thanks.
Thank you. Councillor Kendrick.
Thank you, Chairman. I have to say I'm extremely disappointed that the NHS, whose name is on the report, have declined to present it. I think it's the first time that all the time I've been on this committee that the NHS have produced a report and then refused to present it, and I think that's absolutely appalling, and therefore it's maybe put the gentleman from the Home Office in a bit of a difficult position, to be fair. One of the questions I was going to ask has actually been asked by Councillor Wood, which was in reference to the funding package. Again, I'm rather disappointed we can't get figures on that today. What I wanted to know was, it's main mention about the health screening. I'd be interested to know to what extent that screening takes place and whether is there any subsequent monitoring, because obviously somebody may come to the country and have an illness, but that hasn't presented itself, it hasn't been identified, and it may subsequently occur. And bearing in mind, of course, that I understand that this is not a secure location, that they may go into the community. I just want to know what the screening will consist of clinically, and whether there's an ongoing monitoring. Thank you, Chairman.
So I can comment that I haven't got the full detail of what exactly is screened. I'm told that it is a very thorough blood test screening, and also the first appointment with a GP to sort of go through medical history. So any conditions that are evident at that particular time are treated. The screening then is undertaken, and then once that screening comes back, then that individual is called back into the medical facility. They go through the results of that screening, and if appropriate, any further treatment is administered. So there is ongoing treatment, not just on day one on arrival, but throughout somebody's stay on site, they'll have access to that GP facility for ongoing medical care and treatment.
Thank you. I've got Councillor Smith next, please.
Thank you, Chairman. And I should declare a number of interests first. I direct members to my DPI in the fact that I work for Sir Edward Lee. I'm also a member of West Lindsey District Council and their Planning Committee, and I also am a former resident of RAF Scampton when it was an active Royal Air Force base. Chairman, I'm going to be quite frank. This is an absolute slap in the face to those that used to live on that site and those that live further afield in Welton. We couldn't have facilities like that, Chairman, for love nor money. And then now, miraculously, a magic money tree appears, and it appears, as Councillor Allen has said, this is going to impact locally because we don't have enough GPs, we don't have enough mental health practitioners already. And Councillor Kendrick's point around potential diseases and etc., that's assuming they stay on site, Chairman. I'm telling you now, they're not going to. They will not stay there, Chairman, so it's all well and good saying, oh, we're going to screen them an ongoing treatment. We've already had instances in this authority, we have been asked to take people whilst they've been in hotels, Chairman, and we did not know what diseases they had, and then we ran around frantically because we weren't told by the Home Office what they had, and then we were left to sort it. And it's going to be very much that case again, Chairman, of our residents are going to suffer because they won't see their GP when they should, they won't be able to get into Lincoln County when they should, because we are being potentially forced to take this, Chairman, and you can promise all the money in sundry. It will not cover the bill. And furthermore, Chairman, I take the point that the NHS aren't here to present it, but actually I can't say I blame them, Chairman, because they have been forced to write that report, and frankly, they don't want the flack because it's not them that have pushed this, Chairman, it's the Home Office. I can't say any more around the review process because it's not for this place, Chairman, but it is ongoing, and I hope personally it's successful because this is absolute madness. that we put people in a site where you're in the middle of, essentially, without a vehicle, you can't live at RF Scampton. There is no public transport, there is no infrastructure. So they will either walk along the A15 and go into Lincoln or further afield, or they will get picked up by somebody and go wherever they damn well choose to, because it's not a secure site, Chairman. The implications for health on this county, if this site is granted, is huge. That is 2,000 single, fighting-aged, illegal males who are in this country, who will then put a tax and a drain on our health system that's already at breaking point. You already can't see a GP fast enough, as we've already discussed, Chairman, in previous papers. I don't expect an answer, because I appreciate the gentleman from the Home Office has rather had this landed on him, and a lot of the questions asked he can't answer. And to be fair, Chairman, it's not a question, it's a statement of fact. We will have health implications in this county, so you can have as many GPs, as many screenings as you want on that site. It will impact, because where are the GPs coming from? They are going to need extra treatment. They are going to need mental health, or they will claim they do. I don't know what the individuals have gone through. It's not my place to know, Chairman. But some of them will have genuine mental health. Some of them won't. Some of them will use it as a justification and claim it when there isn't any. But that will have to be assessed at cost to the taxpayer. Frankly, Chairman, this proves this premise, this idea of using Scampton and other places is totally not sustainable. And it's totally inappropriate for Lincolnshire especially, but especially at Scampton and where it is, because it's totally in the wrong place. It shouldn't be on a site that's as relevant to the country as it is, and not when there's a £300 million deal on the line, which I appreciate is for another place, Chairman. So I thank you for indulgence and brevity, because I've probably gone a bit wide of the mark, but I appreciate your brevity,
Yeah, I will
Chairman.
just hone you back in if we can keep it, because this is the Health Scrutiny Committee on NHS Services. It would be, much preferred, although I do take the greater point, but I think that that's being debated on other committees and other places across the county, so I think we'll just try and hone in on there. David, I'm going to add on to Councillor Smith's question, and then whether or not you can answer it in a bit more of a whole and rounded way, I don't know, but we do know locally that Lincolnshire's healthcare system is under huge pressure, continues to have real issues with recruiting and retaining doctors, nurses, dentists, and so on. So my question is, where are the additional services being brought in from? And are you confident that this will remain stable without reliance on the use of what the primary service will have for residents currently?
I think just a couple of points to pull out of there. I think by providing access to primary GP services on site, I think by definition it will reduce the burden on GP services in the local community. I take the points that you and others have made around access to other healthcare services, and I think we certainly have a commitment from the Home Office to work or continue to work with the ICB and healthcare to look at any further mitigations that are needed as and when the site is live and operational, because as we've said previously, we can only plan so far, and we do need to consider the sort of wider impacts, and there may be some wider impacts that are not known at this particular point. Just to correct on a previous point, we will be providing transport for those people resident on the site to be able to leave the site frequently. So that transport is being arranged, but as you've also said, it is a non-detained site, so people will be free to come and go as well. I don't think there's anything much more I can say specifically, other than we are confident that we will be able to provide the doctors and nurses that are required through the staffing up of that medical centre facility, and we don't certainly have any risks that we won't be able to do that. So we are confident in being able to deliver that as and when the time comes. I think that's about all I can say at this point.
So there's no chance in expanding on as to where these additional doctors and nurses, when we're short across the whole of the country, are coming from?
No, I don't have that to hand. That would be a question more for the ICB in terms of where the staff would come from. I'm not close enough to know, but happy again to follow up any supplementary questions following the meeting, and I'll try and get back to you.
Okay, many thanks. Councillor, very briefly, because I've got a number of other speakers.
It is very brief, Chairman, and it's in relation to your point. Will they have access to dentistry on site?
So no, the only provision that I'm aware of for dentistry is very much on an emergency basis, and I think that's because of the potential to create inequality with that dental service that's provided or available to residents locally, not just in Lincolnshire or Scampton, but also across the UK.
Okay, thank you. Councillor Morgan, please.
Yeah, thank you. We're assuming, it seems, that the folk concerned will actually want to cooperate with having the medical examinations. I think that there's several issues, but looking at it from both ways, clearly we would want to ensure that any contagious illnesses and things are contained, but will they have to cooperate? And then secondly, on the tail end of that, what I'd hate to see is them forced to cooperate, given ultimately it's their body, and we don't know what traumatic experiences some of them may have gone through, that actually having an examination in a foreign country by foreign doctors and nurses. There's also, I know, potentially cultural issues here, because if we've got, for example, Muslims or where actually the sex of the people working with them could actually be an issue. So are we taking that into account? Have we got on site to support the medical staff translators, because they may be required? And I know from working in the prison service, that's a big issue, actually, getting the translators to work with people. So this ideal of we'll do all of this on the first day and everything, unless we've got them on site, you know, to be honest, that's a bit of a miracle that would be pulled off to get that. I think it's worth making the point that had we got good, strong local services, had we got good dentistry, had we got good GP access, had local people got the good transport access, I don't think this would be an issue. The problem is that we have 2,000 people being put into a community, really rural, which has been deprived of all of these services for so long. But I think there's some really key questions that I don't think this has actually been thoroughly thought through. And then last but not least, having worked with people with severe mental health issues at night on duty, actually it's night time that very often you will get problems, especially around perhaps suicide attempts. So what support will there be there then? And I believe I'd be correct in saying at that point, actually is when probably our own local services will be most used, actually.
Is it okay for me to respond? Yeah, just checking.
Yeah, just come in straight away each time. That'll be the easiest.
Yeah, sorry. There's a lot in there, and we might need to pick up some of it afterwards. I think there are a couple of points. In terms of the numbers, I know you quote the 2,000, which is the maximum. Certainly what we've done for all our larger accommodation, whether it's the vessel or whether it's the Wethersfield site, is that flow is very controlled, very steady, and is evaluated at fixed points. So it's not a 2,000 in one go. It's a very, very steady flow to make sure that we've got everything right and everything working properly. People will be screened before they come into the site, so they will be screened, and it will be determined as best that we know that they are fit and healthy. So if there are any underlying medical presentations that are serious, any mental presentations that have been known, when somebody arrives, they will be sifted out and they will not be sent into the site. That said, we do have mental health support on site through the services. We also have other staff on site who are there 24 hours a day. So we have fully trained welfare officers and different staff on site who are there and able to monitor and make sure that any issues that are picked up out of hours are identified really quickly. Something we're also trialling for the Wethersfield site is a almost a program of mental health support for residents so that they can be able to support each other and identify issues in people as they do present further down into their journey. So we're not complacent about mental health at all. In terms of access to translation, when somebody arrives on site, they will be properly orientated. We're working very hard to make sure that all of those materials are provided in people's own languages and support is given. And also for medical appointments, we will also make sure that full translation is available as a service so that we've got effective communication with the users. So we have a lot of experience through the operation of our large sites that we've currently got. We make sure that that experience, that knowledge and that learning is fed through into how we plan to operate the site at Scampton. So we're not doing this from a standing start. We're doing this with a large amount of knowledge in the system. But again, happy to discuss more widely and more further. There are a lot of points in there. Hopefully that helps a bit.
Thank you. I've just got two more people that have indicated to speak. So I've got Councillor Wootton first, please.
Thank you, Chairman. My question's already been asked by yourself, actually. Thank you.
Thank you. Okay, I've got Councillor Parkin, please.
Considering what you've just said in terms of knowledge of running your other sites, what percentage of people who have gone through the GP screening then need further referrals to hospital, to inpatients, to other treatment services? And have you used that prior knowledge to inform modelling and pass that on to the local NHS systems as to what other impacts they could expect further up the chain? Because if you're running those other sites, you must have some inkling and some ideas of that. Also, have organisations such as the Lincolnshire Refugee Doctors Project been consulted and worked with, so that if there are GPs, if there are doctors there who have that experience themselves of claiming refugee status, is that a pool of talent and help that you could actually draw on? Have you already been there to ask them those questions?
Apologies, I was on mute there. So in terms of the numbers and data, we do share that, or we have got data that is shared and discussed widely with both ICB and the NHS system. I haven't got that data to hand on the number of referrals to secondary care scenarios. So again, we'd have to potentially follow that up to see if I'm able to provide that. And I think the follow-up question was around our engagement with the voluntary sector potentially. I think there are issues with people who are claiming asylum being able to work with other organisations, but we are looking at opportunities for asylum seekers that are in our care to be able to link in with voluntary sector and also potentially to be involved with volunteering and other activities. And again, that's something that's really important to us and our providers, is to be able to provide sort of enrichment and activities for people on site to keep them occupied and as healthy as possible. So it's an ongoing process, but it's something we are looking at.
Just to clarify, Chairman, I would ask for us to follow up and get that data so that we as a committee are aware of the impact on our secondary services after those GP screening tests. But just to clarify, I'm not talking about a voluntary sector here. I'm talking about a scheme in Lincolnshire which has trained up a number of qualified doctors who are themselves refugees. So these are not volunteers, these are paid professionals. And they are based in Lincolnshire, this organisation. And I think it's really worrying if we have somebody from the Home Office who is not aware and hasn't done their research locally that that group exists and could actually be a pool of professional doctors who are trained up, who are qualified, who have passed the relevant British qualifications, who could actually be an invaluable source of support to these individuals. It beggars belief that at this stage in the process, the Home Office don't know about them. I rest my case.
Again, I'll come back to you on that. I can't speak for the whole of the Home Office, but I will check to see whether we've made any engagement there. But obviously, the provision of care on site will be a matter for the NHS and the ICB rather than the Home Office directly. But I'll explore that further.
Okay, thank you. And very finally, Councillor Welbury.
Thank you. I've got first-hand experience of asylum seekers. My ward is Swine's Head with Holland Fen, and we've had the Supreme Inn and many issues around the Supreme Inn. I'd just like to ask if Serco will be in charge of Scampton, because we were made many promises, but that were not fulfilled due to poor management of the hotel. Healthcare was a particular issue for the residents, many of which had traumatic experiences, but one of the major issues was dentistry. They could not access the dentist. Many were left in pain for weeks, and Serco were not given the support, nor were they trained professionals to actually administer the hotel in an appropriate manner. We asked on many occasions if we could have access to the hotel and set up a kind of a resident management committee. We were denied access. We tried on many occasions to formalise education and also health access for the 100+ residents. We were denied that. It was a shambles, and I shan't say any more, but if anybody would be interested in hearing full stories, I'd be quite happy to speak to anybody, but I agree with my fellow councillors. I'm extremely worried about this, having this first-hand knowledge. Thank you.
Thank you. I do believe it is Serco that's running it, and I think for those of us in Skegness as well, we can certainly.
Then we need to be
side
very,
with your
very.
Side, so. But I'll let Mr. Harding respond, and then
Oh, sorry.
I'll close it down.
Yes, just to confirm, it is Serco, and in terms of our close working with Serco, we will make sure that we work closely to make sure that all their contractual obligations are assessed in real time and fulfilled. And we will make sure, in terms of the healthcare, that responsibility will be the NHS. So it's not a direct Serco responsibility, and we will have conversations with them as and when we become live to look at the issues that are on site and how that's working. So it will be regularly reviewed. I think that's all I can add on that. Thanks very much.
Okay, I think there's no further speakers. I'm going to move to the proposal, and that is that the written report provided by NHS Lincolnshire Integrated Care be noted, that the information provided at the meeting by the representative from the Home Office also be noted, and in the event of this service being implemented, a report outlining any potential negative effects on either primary or secondary NHS services be committed to this committee. And finally, to thank Mr. Harding for his attendance. At least we got some form of representation to try and cover some of the questions we have. So do I have a seconder for that proposal? Councillor Allen. All those in favour, please show. Thank you. That's supported unanimously. And once again, thank you, Mr. Harding, for attending today.
Thank you. Goodbye.
Goodbye. We'll now move on to agenda item 8, the Humber and Lincolnshire Joint Health Scrutiny Committee. This report comprises a summary of the activity of the Humber and Lincolnshire Joint Health Overview and Scrutiny Committee, which met on the 17th of October and the 18th of December 2023. I'm going to hand over to Simon to introduce the report, which is on pages 129 to 175. Simon.
Thank you, Chairman. This, although the action is simply asking the committee to note this, I think the reason for this is a little bit wider, in that this provides an opportunity for the committee to reflect on the work of the joint committee, and also to consider the joint committee's submission or approved consultation response. Just on the pages involved in this report, it does seem like a long report, but that's because the Joint Committee's response attached as an appendix, which is effectively from page 149 to 175, an extract from the pre-consultation business case, which they were using as evidence because none of the, or very few of the right-hand columns had been completed at that time. So that was really why the response is so long. The report itself includes a narrative of the, if you like, a short narrative of the chronology which has led up to the Joint Committee. Initially, the proposal was that we would need a Joint Committee in 2022, but as everyone is aware, the consultation wasn't launched until September 2023. So within this, page 133, I've summarised the two meetings of the Joint Committee which had taken place. And maybe if I could leave the part for the people, for the two councillors present who were at those meetings, the Chairman, Councillor Macy, and Councillor Tom Smith, to perhaps provide any further reflections on the activity. The only other point I would make is that, and it's made in the report and is quite clear, is that all of these submissions from the 5 constituent councils were incorporated within the overall Joint Committee's submission. And a decision is expected, as it says on page 134, by the Humber and North Yorkshire ICB on or before the 13th of March this year. So it's just a couple of months away, isn't it now? Thank you, Chairman.
Would you like to start first, Tom, or should I?
I don't mind, Chairman. As we said in emails when we were discussing this, it is a huge opportunity missed. I personally, the combined response, I think, totally misses the point, quite frankly. The consultation was an absolute farce, and I will use that word because it was a total farce. Veterans were only the forces community was only even brought in after it was mentioned at the first meeting, so that hadn't even crossed their mind, even though it's a legal duty for them to do. And that just that's one example of numerous, Chairman. And then you go to the fact that we didn't have any consultation events until after, again, it was raised by ourselves at the first meeting. I think it was a comedy of errors from start to finish, or it would be if it wasn't so serious. And the Joint Committee wasn't, in my view, anywhere near as strong as it should have been in its response, because it's saying, oh, we agree with the principle. Well, actually, most councillors who were there didn't agree with the principle at all, because actually we all said the same thing by and large, with probably the exception of Hull, which is we're going to be here again in 3 or 4 years' time, because you're not solving the problem. The problem is the ICB and the trust and the wider issue. Basically, the assets are crumbling to bits. They do not have sufficient medical staff across both sites, and they can't maintain both hospitals. And I know they did their best to try and do that through the relevant programme of building a new hospital. I don't decry the work done there, but I do decry how the premise of the consultation, because it's basically kicking the can down the road for a couple of years, and we'll be there again, Chairman, because it's an issue of staffing and state of buildings, which I appreciate in terms of the buildings is not totally within their gift to remedy. I accept that. But it doesn't solve anything. We will be there for maybe not the same departments, but different departments will be there again in 3 or 4 years, because it will either go one way or the other way. It will either go to Scunthorpe, it will go to Grimsby, and my hunch is it will go to Grimsby based off of what we saw there. But I think personally, if it were me, I would have referred it, while we have the duty to refer, I would have referred it to the Secretary of State, because there's so many deficiencies in this process. I certainly wouldn't have just let it carry on through the process, Chairman, but that's what I would do, and it's not within my gift to do that. But I will let you state your thoughts to the meeting, but those are mine.
Yeah, thank you, Councillor Smith. There's nothing I would disagree with what you've just said. Unfortunately, the decision hasn't been made, so you can't refer something that hasn't officially been made. And of course, the erosion of the right to refer will be gone by that point. So, there is no real reason, although there is, we'll cover more about how I think this new system will work later on. But yeah, absolutely, there's just not that opportunity. I think looking at it, we didn't actually agree with this approach either. I think I should make clear that the Lincolnshire County councillors felt that it would be better that instead of each individual council basically submitting what we've already submitted, that there should have been commonalities to give a much firmer response to why we didn't agree with the changes that they are putting forward to be made, and instead all we've ended up with is a copy and paste of each individual committees, and to me that doesn't work, and so we didn't support that route forwards. We felt it would be far better to draw a line in the sand and say, you know, for these reasons we don't support it, and, you know, have that unilaterally sort of supported through. I also think, you know, there were some mistakes made in terms of bringing this committee together, because the reality is the main affected areas will be Lincolnshire, North East Lincolnshire and North Lincolnshire. Hull has only improvements realistically that they will be looking at, and the East Riding of Yorkshire again is barely in any way, shape or form affected, unlike ourselves over this side. I think, as Councillor Smith has so well said, you know, when it comes to travel and transport, they said, I think in our meeting in December, oh, we're just beginning to start work on coming up with a travel and transport plan, and yet had already gone out to consultation. So I think very, very poorly thought out. I think the worst consultation I've known, and I will absolutely commend Lincolnshire's ICB, or as it was previously, obviously, when they did it, at least they went out to every household and they tried to engage. There has been literally no engagement with this, and I think if there was ever a judicial review that could have the potential to stand up, this would be this one in particular. So I don't think there's anything much further I can add to that, but obviously we have in front of us what we're saying and what our next steps are. I will put a proposal forward, but I'm open to any other questions or anything else that's said by the committee. No? Okay. In which case, then, I will make a proposal. I propose that we note the response of the Humber and Lincolnshire Joint Health Overview and Scrutiny Committee to the consultation undertaken by the NHS Humber and North Yorkshire Integrated Care Board on hospital services in Grimsby and Scunthorpe, as set out at Appendix A to this report. That we record the committee's disappointment with the joint committee process, given that in this instance 5 local authorities were selected by the NHS Humber and North Yorkshire Integrated Care Board as participants in the joint committee, and there was minimal or no impact on the hospital services in 2 of these local authority areas. And finally, that the committee's position of not supporting the NHS Humber and North Yorkshire's Integrated Care Board's proposal for acute hospitals in Grimsby and Scunthorpe be confirmed because of the potential negative impact on Lincolnshire residents and the lack of planning with regard to travel and transport. Do I have a seconder to my proposal? Councillor Smith. All those in favour, please show. That's supported unanimously. Thank you. Okay. In which case, that takes us on to agenda item 9, which we've already covered. So I'd like to thank you all very much for your attendance and for your questioning this morning. It's appreciated, and I look forward to seeing you at the next meeting. Meeting closed. Thank you.